waiting for my teams to catch up, just with all the people coming through. Right.
That's fine. Kate, you may as well do an introduction quickly if you want, and then you can get yourself away if you need to be.
Find some better Wi-Fi. Good afternoon, everyone. We're delighted that you're able to join us. We are hosting this afternoon, as you will know, a meeting about the management of obstetric cardiology issues during pregnancy, hence the word obstetric. I'm delighted to be joined by colleagues from the hospital that I work in, which is in the Leeds Teaching Hospitals NHS Trust, and also colleagues across the northeast of England from the Newcastle Hospital Trust and South Tyneside or South Tees. We are going to start, or the focus of this meeting is to talk a lot about not those complete disaster cases where things go really wrong, but to give you a bit of confidence in managing some of the commoner cardiac issues during pregnancy, talk to you about how you can access and how you can utilize the new maternal networks in ensuring that your patients who have cardiac disease in pregnancy have pregnancies that are well monitored and as safe as possible. And I think we're going to start off with one of my colleagues, Thomas Everett from Leeds, who's a consultant obstetrician, talking to us about the interface between heart disease and pregnancy. We're going to take questions at the end. I think you can use the chat function throughout, and those questions will be moderated. So I think I'm handing over to Tom.
Oh, I thought you disappeared then. Hi. Right,
no.
Let me get my slides up in that case. Is that now sharing and in full screen?
So we can't. Yes,
there you
sharing,
go.
Tom, and we can hear you and see your slides.
You can. Great.
Lovely.
Hi.
Thank you.
Good afternoon. Thank you. I'm Tom Everett. I'm a consultant obstetrician and subspecialist in both maternal and fetal medicine here in Leeds. Why is that not progressing? So we've been talked about heart disease in pregnancy, and as Kate said, a lot of it is about what can be handled in outside the maternal medicine networks and in the normal hospitals. So in most cases, not very much is the answer, but that would make an extremely boring talk and very brief talk for this afternoon. And we do have to bear in mind the Embrace reports. For those of you who are cardiologists, this is a triennial report that happens across perinatal outcomes and also our maternal outcomes. And on the left of the screen are the is a report from about a decade ago, and you can see that cardiac disease was up at about 2.3 mortalities per 100,000 pregnancies. And there has been a reduction over the past 8 to 10 years, and in the last report that was down to 1.73. That second bar there you can see is COVID, and the first bar that's overtaken cardiac disease in pregnancy is thrombosis. So cardiac disease, once we take COVID out of this, because that skew of the picture remains very high, either first or second, as the causes of maternal mortality. So whilst many cases are straightforward, there is still a significant mortality and morbidity caused by cardiac disease in pregnancy. And this is slightly older data, but it still holds true. If you look right down at the bottom, these are the women and the percentage of deaths from cardiac disease, and you've got congenital heart disease down at the bottom. And actually, a lot of the deaths are due to cardiomyopathies, myocardial disease, aortic dissections, and increasingly ischemic deaths. And when we see the revised figures here, you see that again. If you take the ischemia 20% and myocardial cardiomyopathy 25%. So we're seeing a big burden of disease outside the congenital sphere. So I just want to spend 10 minutes or so going through how we get from a couple planning a pregnancy through to actually the aim of this to deliver a well mother and a well baby, and the issues that might come into play, and the effect of the heart disease on the pregnancy during that time. Key to this actually is that preconception counselling, and number one on my list here would be contraception. Next would be optimization. You know, is the heart ready for the pregnancy? And I'm going to gloss over a lot of this because a lot of this is going to be covered in later talks. And part of that optimization, which may involve assessment of cardiac function, either by echo or exercises, is that medication review. And we'll think a little bit about this in a minute. You know, are the medications we have safe for pregnancy? Are they appropriate? Some of them, such as metallic valves and warfarin, the women who want to keep the women on the warfarin. And so that early engagement with services, that point of knowing that the woman is pregnant, that early engagement, early flagging up is really important, getting that message across early, and having that ease of access to the service is essential. Risk assessment, that individualized risk assessment we need to do. There are various scoring parameters. There's the CARPREG 2, WHO, Zahara scores. And also, particularly in the high-risk women, thinking about alternative options. Are there options such as surrogacy and adoption? And I'll say it again, and I think there's a talk at the end of our afternoon, contraception is key. Trying to avoid unplanned pregnancies in women who aren't medically ready is so important. So what do we do when we've got that positive pregnancy test? That is just the start of a whole load of hurdles through a pregnancy. First, the hurdles is sadly miscarriage. And when we look at women, even with moderate and particularly with severe cardiac lesions, we're talking things like Fontan circulation, TGA, this meta-analysis put together, double outlet right ventricles. There's about a 33%, 34% miscarriage rate. And that compares to a rate of about 10 to 20% somewhere in a normal control population. And when you look at some congenital cardiac anomalies, such as the Fontan circulation in particular, there are reports of up to 50 to 75% miscarriage rate in these pregnancies. So we've got over that first hurdle. Pregnancy hasn't miscarried. And the first thing that is going to happen then is the first trimester scan, the fetal scans. And one of the things we look for in the fetus to start with is the nuchal translucency, a bit of fluid behind baby's neck. And that can either be a marker of chromosome disease, it may well be normal. It's also a marker of cardiac disease. And increasingly, I'm fairly sure this video is not going to work. No, it's not. And increasingly in the first trimester, this is a baby I scanned a few weeks ago. And this here is the right atrium, very dilated. These are the ventricles here. And you've got significant tricuspid atresia and evolving cardiac disease. So in these women, having an early echo and a fetal echo is essential, and perhaps bringing these earlier is be able to see more earlier with the increased resolution if you've got a service who can provide first trimester scans. Because what we do see is an overall rate of fetal cardiac lesions of about 3 to 5%. Interestingly, there is a degree of concordance when you look between the groups, and particularly high in the septal defects. And also, as you get recurrent pregnancies through the family, there is increasing concordance there. So moving on to really when there are conflicts between the mother's interest and the fetal interest. You know, warfarin I have talked to, and there's a presentation on valves, so I won't go into great detail on it, but there is a very careful balance between warfarin and that warfarin fetopathy and embryopathy that we see, and that risk of thrombus on the valves in particular. ACE inhibitors, quite common to have mums on ACE inhibitors, particularly those in the cardiomyopathy spectrums. And again, stopping these early and really optimizing the medication is key, because long-term use has significant impacts on fetal liquor in a lot of cases, and can impact fetal renal disease. Beta blockers, almost ubiquitous in our clinics, probably less of a problem than previously considered. They may make a couple of 100 grams on a baby's birth weight, but once you take the cardiac disease into account, in some cases it's down to a few tens of grams. And again, I'm sure fetal warfarin syndrome will be mentioned later, or that dilemma about warfarin and valve usage. And moving on, we've got a baby, we've got the heart scan, we're moving on through the pregnancy. Is my baby going to grow? When is my baby going to come? And again, we see a high chance of small for gestation age, particularly at the severe end of cardiac disease, 35% in this pooled estimate. And this has been known for quite some time. And the other thing to bear in mind is this prematurity that comes into play as well. When we look at preterm delivery, you've got this group here, 19%, 33% coming before 34 weeks gestation. And not only are the babies smaller, there's a tendency to prematurity. And apologies for the writing on this slide, I must send me a proper one. But basically, this is the comparison group. You should maybe have to read that. This is birth weight adjusted for parity and maternal age. So this is the normal group here. And then briefly, this is cardiac severity going across to Fontan circulation and pulmonary arterial hypertension, cardiomyopathy down this end. So you can see effectively as the cardiac severity increases, there is a reduction in birth weight. And similarly, there is a tendency towards earlier gestations, particularly at this more severe end. And we shouldn't ignore this long tail in a lot of these groups here of babies coming earlier. Because when we do see these babies coming prematurely, particularly before 28 weeks, there is significant rates of, sadly, neonatal mortality that we see, and also of neonatal morbidity. When we look overall at the groups, we've got neonatal mortality, about 3.5% in the severe group overall. Some of these conditions, particularly the Fontan circulation, will have much higher rate. We've got a high rate of miscarriage, prematurity up to 50%. And again, these are in small babies, so not only premature, but premature small babies, which makes that risk of complication, and not just the mortality that we're seeing on this left-hand side, but also that long-term morbidity greater. Things such as chronic lung disease, cerebral palsy, and other associated factors with prematurity, necrotizing enterocolitis, etc. And just briefly, this is more on the maternal side of the maternal cardiac side. you can see as the WHO classes increase, as the CARPREG scores increase, you're getting into higher rates of maternal complications, which is worth mentioning because you need a well mother to have a well baby. I just wanted to highlight the psychosocial burden that we see. This is a woman we've looked after a few times, and you can see that she's got a mechanical mitral valve, so up at the most complex and high risk end of the group we look after. And you can see this playing out. She's had a successful term pregnancy previously. She's had a 20-week loss. She's had a preterm loss and a miscarriage. I just wanted to highlight this as well. These are her clinic appointments, her routine clinic appointments with us. And then down here were the ward stays. She was an inpatient with us for nearly 6 or 7 weeks, leaving her children at home over an hour away. During her inpatient time, she had 5 further echoes. I lost slight count for anticoagulations tests, but it was well over 20, and further 40 inpatient ward round episodes involving the cardiac team. And what I've blanked out there is health-related anxiety. This really has a huge impact, the heart disease on the women, that burden on the families that need to attend appointments, and that psychological worry about both themselves, their families, and their babies. So moving on to our delivery options, we have broadly 2 options in obstetrics. There's the option of vaginal delivery and there's the option of caesarean delivery. And when we think about the mode of delivery, there is really very few strict indications. This is from the ESC recommendations. There are very few strict indications for caesarean delivery. Really, they're down to symptomatic severe aortic stenosis and also those with aggressive aortopathies, the Marfan's, the Lewis Deeds, those with significantly dilated aortas. And again, timing of delivery. When I started in Leeds 8 years ago, we used to deliver a lot of women at sort of 37, 38 weeks, but increasingly we've now moved to treating these women much as we would others, maybe bringing it forward a week, but timing delivery, if we feel the need to time delivery, at around 39 to 40 weeks. There's increasing evidence of less or no detrimental effect to most mums going through, and also improving those neonatal outcomes, reducing that need to go to the neonatal respiratory morbidity, etc. So timing of delivery broadly in keeping with the general population, but of course it needs individualizing case by case. And then in some cases, particularly those with the aortopathies who are aiming for vaginal delivery, we do modify the labour. And what we do in Leeds is we advise an epidural and take that vascular pressure off, and particularly during that pushing stage. We allow 2 hours if the fetal heart rate allows, if the mother can tolerate it, if there's no infection, etc., for passive descent in the second stage. So that's getting to full dilatation and letting baby's head come down and into a much more favourable position if we can allow it, so that we hope to minimise the pushing. We limit pushing to around 40 minutes, sometimes less, sometimes more, depending on the exact underlying condition and the measurements, any progression during pregnancy, etc. And if delivery is not imminent by 40 minutes or 30 minutes, whatever we've determined, then the early recourse to operative delivery, either instrumental or caesarean delivery. And we've just pulled our data together, and very preliminary, what we are seeing on average by doing this in our cohort is a delivery on average at about 29 minutes, and vaginal deliveries and cesarean rates comparable to our normal population, slightly higher cesarean rates. What we have seen is slightly higher in postpartum hemorrhage, but we're just working through that preliminary data. But most of the women were delivering in just under half an hour. So these are our maternal medicine network referral criteria. And as you can see on the right-hand side there are lots of these that can be looked after in hospital under local cardiology teams. And the deliveries are those red and orange ones that we will take on in Leeds. And again, this is our congenital list here. If you're interested in finding them, you can go to the Yorkshire Humber Maternal Medicine Network, and the criteria for referral are set out there. So we can get from this to this, but there are significant hurdles in the way, and we can overcome these, and it takes a lot of careful planning. But despite all that, unfortunately, we do fall at some hurdles, and we must be cognizant of the complications that the heart has on the pregnancies of the fetus, right through from conception through to the mother delivery and also their families. And to do all this, we have quite a large team here. You can tell who has their profile on social media and which come off trust websites. We have Joy and James on the congenital side, Kate and Alex on our acquired and cardiomyopathy side. Myself and Caroline, who you'll see later, are the obstetricians, and I have two anaesthetists I can't find photos of, Tis Halsey, Stuart Presswich, and just joined us this year as the maternal medicine centres have been, and it's hugely valuable for that liaison across and that coordination with the women, is Natalie, our maternal medicine midwife. So there's a large team for seeing these women through their pregnancies and prior to pregnancies and following them up afterwards. So I think we are having questions at the end, but be very happy to take.
Okay, have we got any questions? We can put them in the chat. Or we're happy to leave it till the end.
Looks
Okay,
like you're off the hook, Thomas, for now, so we'll leave it till the end then, Nicola.
Okay, no problem. So who have we got coming up next, Terry? Sorry.
I think we have Caroline Shaw, who's doing the role of maternal medicine networks and risk stratification. Is that right?
Yeah, hello, one sec, I'll get my slides up. Lovely. So hopefully you can all see and hear.
Yes, you're great. Thanks, Caroline.
Great. So afternoon, everyone. I'm just going to speak for the next few minutes about maternal medicine networks, which is something that Tom's already touched on a little bit, kind of thinking about why we need them, what they are, how they're working, and then I'll just focus a little bit on their risk stratification and relating that to cardiology clinics and explaining how that you can access these networks for your patients. I'm not really going to go over and repeat how pregnancy affects cardiac disease and cardiac disease affects pregnancy, but I did want to just briefly touch on why maternal medicine is an important field, essentially. And what we have for people who are not in obstetrics is Embrace. So this is a national audit confidential inquiry body that looks at as one of its roles, looks at maternal deaths and examines the reasons for, but also trends in that. And what we have seen over the last decade or more is that they're reporting that whilst maternal death is thankfully rare, the rates are overall static and cardiac disease remains this important contributor. They're also tracking trends in pregnancy, and we know that there's an increasing number of women with pre-existing medical conditions who either choose to become pregnant, so a deliberate pursuit of pregnancy. A lot of this is to do with sort of more information, changing expectations of what you may, be able to manage with chronic disease. Also, we are seeing increased rates of unplanned pregnancies, either because people aren't aware of the risks. Pre-pregnancy counselling can be challenging to access, and contraception is becoming more and more challenging in some cases to access for women. We also know that there are increasing age of mothers, and there's increasing rates of obesity. So we are seeing more women having first presentations of medical conditions in pregnancy, which contributes to poor outcomes. And as you would expect for any report that looks only at maternal deaths, suboptimal care is overrepresented compared to sort of the day-to-day care that we're likely to be providing. But a consistent theme for women with medical conditions in pregnancy is that where it goes wrong, it's a lack of joined up care rather than any individual part of the care necessarily that contributes to the poor outcome. And the actual sort of descriptions of what happens are different, but it comes down to the fact that you have quite subspecialised teams delivering their subspecialised care and doing that separately rather than a joint team bringing together specialties delivering comprehensive care. That is what the woman needs. And the other thing that these reports are increasingly picking up is the impact of both social deprivation and non-white ethnicity on the women who die. These differences are persisting and they are getting worse. They're already recognised as barriers to healthcare. And then if you add that to the fact that healthcare is being delivered from different disjointed services, that's another barrier that probably contributes to what is going wrong. So we understand, even without any of these barriers, that navigating a pregnancy with additional health needs is complicated as a system function. There are a number of teams who most of whom are not involved for the duration of the preconception, early pregnancy, late pregnancy, postnatal period, who have different roles, who are delivering healthcare often in different physical locations, who are recording their assessments on different systems, which may not communicate or be accessible to other teams. They may not all be fully aware of each other's roles, capabilities, capacity, resources, and they may not be aware of how to effectively communicate with each other in a sort of real-time or near real-time fashion. And more what we see is pregnant women as telling us they become the coordinator for their pregnancy. So if they have the capacity to do that, and some of that is about their time, it's about their anxiety around the health, it's about their financial situation, it's about their language capabilities, then they can sort of achieve a more streamlined, coordinated pathway. But if they can't, because they can't afford the time, they can't afford the time off work, or they simply haven't, they're too anxious about it, they can't deal with it, then this is the area where they don't always get the same level of high quality care that we would hope to provide. So this is the background from which the need for maternal medicine networks really is stemming. And they've been around for probably longer than a lot of people realise. They were part of the Maternity Transformation Programme, which was published and launched around 2016. And I think most people are aware of the idea that stillbirth would be reduced by 50% by 2025. However, it also included an aim to reduce maternal mortality by 50% by 2025. And the graphs that both myself and Tom have shown, I don't think we're close to achieving that. But it included maternal medicine networks as a concept that might address some of these recurrent themes that were coming out of confidential inquiries and audits as to why women with medical health problems were at an increased risk of death. Jump forward a little bit to the Ockenden review. So this, again, for those of you who are maybe not familiar, is an independent review of maternity services at the Shrewsbury and Telford Hospitals Trust. It went on for a long time, but there was an interim report published in 2020, and this contained immediate and essential actions. One of these was a strong recommendation to look at strengthening maternal medicine networks, and importantly, in response to this report, there was further funding available, which brings us forward to today, where we have a functional maternal medicine network across the country. And there are actually, within England, there are 17 maternal medicine networks. I know the audience is not just Yorkshire and Humber, but because that's the network I work within at the moment, I'm just going to talk about that. So these are large geographic areas which contain one or two, typically a tertiary unit, acting as maternal medicine centres, and then they work with all the other trusts or hospitals within the region who are providing maternity care to deliver an overall sort of a standardised and a high standard level of expert care to women with complex medical conditions. So the map that we've got on the right shows the Yorkshire and Humber area. The names in black are all the maternity units, and then I've just sort of starred, we've got Leeds and Sheffield as the two maternal medicine centres. And these are the stated aims of the maternal medicine network within Yorkshire and Humber. So to provide advice and planned care for women with pre-existing medical conditions before, during and after pregnancy. To provide advice and additional or an escalation of care for women with medical conditions during pregnancy and after, or passing them on to adult services as needed afterwards. To reduce inequalities in and around pregnancy care. And also some of this is not direct frontline care, it's about developing referral pathways for pregnant women, identifying key principles so that local units can incorporate these into their guidance, and then providing education and training, increasing awareness, making people aware of what resources we can provide. The structures vary in terms of who is within the maternal medicine network team, but generally it is broken down into a lead obstetrician, and they will work with and be supported by obstetricians who either have a subspecialism training or special interest in different areas of maternal medicine. There will be a lead physician, and sometimes that is an obstetric physician who's done additional training in a sort of obstetric physician training program, but may equally be a physician who just has experience and interest, and they again work with physicians who have a special interest, in their subspecialism, but also in providing care for pregnancy. There will be a consultant midwife, and they are working supported by a team of maternal medicine midwives, and these are located both in the maternal medicine centres but also in local hospitals. And this is all underpinned by a network of admin support managers who are there to make sure that things are working as they're intended and as they should. So if we jump back to our idea of the complex journey through pregnancy, this is how maternal medicine centres are envisaged to sit within that, linking in with areas where women may present either with an acute problem or to access healthcare, and they are designed to be a stable and visible point of contact with a centralised referral pathway. Part of their work, as I said, is not necessarily frontline healthcare, but they are involved in MDT discussions. So this is sort of within the network itself, monitoring the work of the network, the flow of patients through there, and also making available and facilitating ad hoc discussions if there's a particularly complex or time-sensitive case where multiple teams need to be brought together to finalise a plan. And the level of input that is needed in terms of what the maternal medicine network will do is based on risk stratification. So this is the model that is published within the NHS England guidance. So we have a sort of moving inward circular target or something. Anyway, category A, these are the least complex conditions which can be managed by local expertise. The network will be aware of them, but if things remain stable in the absence of new concerns, it's unlikely the patient will really have contact with a maternal medicine centre or need to travel or deliver at one. Next, category B is women with what we recognise to be more complex conditions, so where input from maternal medicine is needed. This is often envisaged sort of an ongoing advice and guidance with interim reviews, either face-to-face or virtually, but the majority of the care remaining local and delivery tending to remain local. Final category C is for the smallest number of women who have the most complex conditions, and this is where, regardless sort of where they book the pregnancy, care is really led by the maternal medicine centre, and it typically includes a plan for delivery at one of the maternal medicine centres. The criteria for referral have been developed using the NHSE Maternal Medicine Service Specification, which was published in 2021. And whilst this is a national document, it's not necessarily a sort of one size fits all. So for cardiology within Yorkshire Humber, this was tailored in line with the pre-existing pregnancy care guideline that was involved in running the cardiac service that was already present. And there have been further amendments made to reflect local expertise and capacity at both Leeds and Sheffield, both of our MMCs. So the idea is to provide shared care which improves patient experience and outcomes, but it requires us communicating and working together to do that. This is not just about sending all of the patients to Sheffield or Leeds and having everyone have their babies there. So I'd finish by having a look at some of the criteria. You've already seen some of these, so they're divided into congenital and acquired. These, and this is just an example of how the guidance has been a little bit tweaked for our region and may not be the same everywhere else. So this essentially is category C, divided into two different areas. So all are going to be led by the maternal medicine centre, but giving an idea by categorising them into orange and red about the urgency perhaps with which they need to be seen and we would expect to be seeing them. We then move on to the category B, who are in the sort of very pale yellow, and a small number into category C in the category A, sorry, in the green. Similarly, we have a slightly smaller table for the acquired, and again, red and orange are the two category Cs that we're seeing, and yellow and green being our B and C. So I've put the website at the bottom. This is for the Yorkshire Humber website. They are obviously an early adopter and got a really good web address, but a Google search should direct you to your regional maternal medicine network if you're not here. So just to finalise, this is our referral form. So it comes through in a standardised form, gives us the information that is needed to understand the condition and make appropriate recommendations, appointments. It's also, because it's giving us standardised information, allows us to collect data, to audit the service, to populate KPIs, and will come along with standardised single email addresses so that all the referrals are coming to a central place. So really, this is the most appropriate way to refer patients, and probably the easiest for you as well, because it's providing consistency, it's providing oversight, and simplify things for the patient, simplify things for the clinicians involved. Again, if you're not in Yorkshire Humber, there will be an equivalent form and there will be equivalent central email, whatever network you're within. And the standard health and safety warning that I think I'm required to provide is maternal medicine networks are not a 24-hour service for acutely unwell women. If you're not in obstetrics and you're seeing someone who's pregnant and you're worried about them and you want obstetric input, contact the on-call team at your local unit, and then they can liaise with the maternal medicine centres if appropriate, if needed, in terms of transfer. And that's all I have to say. Thank you very much.
Wonderful. Thanks so much, Caroline. If there's any questions, we can pop them in the chat. Oh, there is one question, Caroline, that you might be able to respond. Julie Parker's asking, are there any plans for Hull becoming a maternal medicine centre? Is that the right question, Julie?
Yeah, I can see it in the chat. I'm not aware that there are any. No, I think the network at the moment is in the form that it's planned to be in.
Yeah. Okay, thank you. Wonderful. I think that's it for questions. We're ploughing ahead, so that's pretty good. I think, James, are you next discussing congenital heart disease altogether?
Yes, I think I've got
happy to go
a couple
ahead?
of talks back to back, so we can probably I'll do the first, and then we'll see if there's any questions, and then
Fabulous, thanks. There you go.
Right.
I can see you.
So hopefully you've got my full screen slides.
We have, James, thank you.
Lovely. So I should have spoken to Tom before this, because he's already mentioned this case. So this is only a few minutes, but we were trying to focus on the kind of role and link with local centres. So this patient was quite a recent, interesting one. So I'll go through it in a bit more detail that Tom mentioned, but you're already partly familiar. So she's a 33-year-old, and she lives a fair way from us in Leeds, 90 minutes car journey on a good run. And her cardiac background is one of congenital mitral valve disease, for which she required a mechanical mitral valve replacement, a 27mm St. Jude valve, when she was 12. So a fairly old valve now, a kind of a modern valve, but it's been in for a good couple of decades. And her obstetric history is outlined there. So she did have a successful pregnancy that was fairly uncomplicated when she was 20. She unfortunately had a intrauterine death at 20 weeks when she was 26, and then shortly after that had a premature delivery just before 28 weeks. And then a few years later, just last year, she had an early miscarriage. By this time, she's 32. There'd been quite a lot of discussion about whether she should add to the family, given the cardiac risk of having a mechanical valve. But that was all extensively covered. And on the plus point, she'd never had any cardiac complications during any of these pregnancies. So the pregnancy we want to discuss, so she becomes pregnant fairly soon after the miscarriage last year. Her mitral valve replacement is well functioning. And I'm not going to go into the kind of the big talk about mechanical valve pregnancy, but for those who aren't familiar, it's really just to be aware this is very definitely a very high risk pregnancy that requires very careful management of anticoagulation and assessment of valve function. So she's converted to low molecular weight heparin as her anticoagulation at around 5 weeks, also given aspirin as much for her obstetric history as anything else. And one of the things that we often find quite challenging for mechanical valve pregnant women who don't live near us is making sure that we get appropriate anti-10A levels done in a timely fashion. It's often we find that we can often do it most reliably if people come to Leeds, but of course that's quite difficult. But we did actually manage to get some appropriately timed anti-10A levels done locally and get the results quite quickly. So that all went quite well. And then she was switched back to warfarin, which was the plan for the remainder of the pregnancy from about 13 weeks. And she also had regular review by the preterm team and had some progesterone pessaries because of the background. At 20 weeks, from a cardiac point of view, we noticed an increased gradient across the mitral valve replacement. She's got pretty good echo. The leaflets look fine. She wasn't breathless. And so all we did at that stage was we felt that we should give her a slightly higher INR range, so increase that to 3 to 4, from 2.5 to 3.5, and then reassessed her a week later. No change in her echoes, which was no further change in her echo, which was reassuring. Still asymptomatic, and was just given some low dose bisoprolol furosemide for that gradient, which potentially is sort of a degree of effective mitral stenosis. At 26 weeks, she's reviewed, a detailed emergency delivery plan is generated, and that's shared with her local hospital, because of course that's where she might present if things did happen acutely. And at this sort of stage, she starts to get lots of tightenings and a sensation of pressure in her pelvis. And of course, this is the sort of time that she it's a few weeks after she lost a baby a few years ago, and it's now the time that she delivered prematurely a few years ago. So she presents to a local hospital. As Tom has already mentioned, she's understandably anxious, but and this is probably mainly from her description of her interaction with the local team. Her local team are at least as anxious as her, and I think it all confounds itself. She's understandably very concerned about preterm labour with her background, and of course that anxiety is exacerbated by that distance from the team that she knows in Leeds, and whether it's fair or not, a degree of lack of confidence in the local team, partly related to their apparent lack of confidence in managing her. At 28 weeks, these tightenings lead to an admission in Leeds, and then she's still an inpatient a couple of weeks later, has ongoing tightenings, as Tom has alluded to, lots of interaction with the medical team as you'd expect. She's an inpatient. She feels the baby's further down every day. I think we were heading towards Australia by the time she actually delivered this baby, and her objective risk of labour was calculated at 25%. Of labour before 37 weeks was calculated at 25%. And given that there seemed to be this elevated risk of preterm labour, rather than plan to convert her to low molecular weight heparin pre-delivery at around 36 weeks, we brought that forward and thought we should do that at 33 weeks. And at this stage, we did discharge her, but she then presented about 4 weeks later to her local hospital with more of the same symptoms, really, abdominal pain, very concerned about going into preterm labour, for which there was no objective evidence, but she wasn't kept in the local unit very long, despite that lack of evidence of being in labour, and was very rapidly transferred to us in Leeds. She was nearly at the point at which we were planning to switch her to low molecular weight heparin, so we did that just a few days early. And of course, there was this kind of tension between her being understandably very keen to get back to her husband and kids, but at the same time, this particular concern about going into preterm labour a long way from us in Leeds. She didn't, though, develop any objective sign of going into labour, but we did have some concerns about how safe her management might be in the local centre. On the plus side, there were no issues with the valve. We were very happy with the heart, and the baby was doing fine. So we got together at about 34 weeks, so a week and a half after she'd been on this latest admission, with us in cardiology, the obstetrics team, and the haematologists, and came up with a plan that we would probably try to induce her at 37 weeks if that all seemed favourable, and that we felt that she should remain an inpatient until delivery, and those detailed delivery plans were updated. And thereafter, it was all really rather uneventful. And from a medical point of view, all along, it was really rather uneventful. She had her induction as planned at 37 weeks. She delivered fairly quickly. She was re-anticoagulated with increasing doses of low molecular weight heparin uneventfully for about a week before she then restarted warfarin, and she was discharged 9 days postpartum. And so, you know, in the end, it's all turned out very well. She's baby's fine, heart's fine, she's fine, but she was in hospital and away from her family for more than 8 weeks from 28 weeks, and that wouldn't have been necessary if she'd lived closer to us. So it really was a function of her distance from us in the centre in Leeds, and we had quite a lot of discussion about whether that was necessary. And perhaps one other point is that we generated this very detailed emergency plan, which I think probably potentially could have been followed locally, but it didn't really provide the sufficient reassurance that she could be managed locally. And so we ended up defaulting to keeping her in, and her getting quite bored on the ward in Leeds. So it was really just to, I don't know if anyone's got any questions about about that at all, or feel that we would have done any comments about whether others might have done it differently?
There's nothing in the chat as
Nothing in
yet,
the chat.
James, or something odd popped up there.
Okay, well, I'll start the next presentation, and if anything pops up.
I think there is a hand up.
Oh, there's a hand.
Oh, Justina, did you want to say something, Justina?
Yes, thank you. Thank you, James, for presenting. Sounds as a very challenging case in terms of management. As you said, looked at loads of tensions and anxiety from both patients and the local team. But yeah, happy to hear that in the end, successful pregnancy and delivery. Just a shame, as you say, for a patient that it brought so much stress. But I wanted to ask about your maybe practice on warfarin and low molecular weight heparin. Assuming patients would, is it your routine practice that you switch to warfarin later for the second trimester, or is it really, was it in this case because patient lived far along and would be difficult for the anti-10A monitoring?
I think in this particular case, no, it's very much a case by case decision on method of anticoagulation. I think in this case, we were probably pushed towards warfarin rather than low molecular weight heparin, because it's a mitral valve and it's an old mitral valve with a slightly high baseline gradient, and so we felt that pushed us towards the kind of more reliable level of anticoagulation that you get with warfarin.
Okay.
Rather than anti-10A monitoring and the rest of it.
Yep. Okay, thank you.
James, there is one question from John Anderson's asking, what contraceptive advice did she get before discharge?
Now she is, I can't remember. We've got a plan, and I think I think it might be that she's now going for a coil.
I can't remember either,
remember?
James.
Yeah, it's whatever it is, it's sorted. There's a definitive plan. She's absolutely sure she's not having any more, and she's going to have a very good method of contraception. She's a very reliable person.
Fabulous. Amanda Barnes has got her hand up. I'll just see if we can put you on mic. So Amanda, did you have a question? You're on mute at the moment. You can unmute. No, that's not going to work.
There's
on,
one other.
Oh, there you go.
Oh, okay.
Sorry, you were saying that the plan of care wasn't received confidently. Was that the local hospital, or was that the woman didn't perceive the plan of care would be?
I think we've shared it with the local hospital. I mean, I think it was received. I think it's quite difficult to expect people to be particularly confident managing this patient. So, but I suppose my only point was that I think we felt that we had this very detailed plan, which was, very much step by step. Should she present, this is what you do with her anticoagulation. So to facilitate a degree of confidence in that, should she present locally, this is what you do. But in reality, the experience was that as soon as she hit the ground there, she was shipped over to us. And it's incredibly unfamiliar territory for people. So that's not in any way a criticism. I think that's completely understandable.
Is that something that we're hoping that the actual ethos of the whole maternity medicine is going to try and rectify those challenges? I presume that's what the whole.
I suppose more familiar. I suppose the more we kind of work with each other and develop some confidence with kind of how we jointly work together, then maybe. I mean, I think this in some ways, this is a particularly high risk case, and so I think it would be understandable if people didn't feel particularly comfortable. So I don't know.
It's something to be reviewed in future. Yeah. Okay. Thank you.
Thanks. Stephanie Howden, I think you have a hand up as well. Do you want to ask a question?
Yeah, so this case rings a little bit of a bell to me. And I believe this lady was managed initially locally by the preterm birth clinic. And I don't think she crossed the path of the maternal medicine clinic within that local hospital. And I wonder if that discussion had been had, if there may have been more confidence, particularly as her gestation increased, for her to be managed locally. So I'm just asking that question, when there's been more complexity. So this lady had a history of preterm birth. Sometimes maybe the local leadership might need to change, and the discussions may need to be had, because I don't think she was discussed with the local maternal medicine team, or I think she was always shipped out before that discussion happened, if I put it like that.
Yeah, potentially. I don't know. To be honest, I'm not quite sure exactly what discussions were had at kind of at that sort of level. I mean, I think the patient herself had a huge amount of she knows us as a cardiac team very well. I think she was probably only going to have confidence with us. She also knew one of the obstetricians in Leeds related to her prematurity, and had complete confidence in him, so was very keen to see him. Yeah. So I think she was always going to want to have that direct input from those people in Leeds, to be honest.
We do have a question in the chat. What would be the recommended anticoagulant target for such a woman with metallic heart valve?
We generally aim for peaks of 1 to 1.2 and troughs, a bit more debate about, but around 0.6-ish as a general rule.
Great, thanks, James. I think there's a bit of to and fro in the chat, but I don't think I've missed any questions. If anyone else wants to shout, if I have, I don't think so. And there's
did we see a question from Ada about the warfarin at 13 weeks? There was the conversion.
No, I've missed that.
Yeah,
oh yes,
I can see that. There's one above that. How often do we manage these cases? I think we've probably usually got someone with a mechanical valve going through pregnancy in the unit, so maybe 3 to 5 cases a year or something like that. So small numbers, but regular numbers. In terms of the switching to low molecular weight heparin, so warfarin embryopathy is something that occurs between 6 and 12 weeks, and the embryopathy specifically doesn't occur either before or after that, although there are risks of warfarin, other risks of warfarin beyond 12 weeks. So that's the reason for switching to during that particular period. And the period of switching can be quite risky as well, because obviously you've got to come off one and go on the other. So there's a particular period of intense monitoring if you are switching, and that is sometimes done as an inpatient.
Wonderful. I think now we're safe to say that that's all the questions, James.
Okay, fine. Are we on time? Because my next talk's not to. Do I need to go quickly, or are we all right?
No, I think you're okay actually.
Okay,
just bear with me 2 seconds. Yeah, I think we're fine.
Fine. Okay. So this next talk is a little bit about, just thinking a little bit about the sorts of cases that might be suitable for local delivery who have congenital heart disease. So a few general thoughts about this to start with, and I think you've seen already some reference to the sorts of conditions that, according to risk, might be suitable for kind of local management and local delivery. But I think there's some, it's obviously a question that we consider very frequently in the cardiac obstetric clinic. And I think the first thing I'd say is that I don't think there's any expectation for really anyone other than an ACHD cardiologist, plus or minus an experienced obstetrician who works in the cardiac obstetric clinic, to make that call. And when I say that, I don't mean that we will decide where women deliver, but I think we are the people who can work out what we think the risk is, and then have that discussion if we think that is appropriate. But we're not expecting anyone else to kind of make that judgment, if you see what I mean, about what that risk is. So I would say as congenital cardiologists, we want to be contacted about all pregnant patients with congenital heart disease, or all patients with congenital heart disease who are considering pregnancy. And it may be something we can deal with very quickly if the risk is low and be reassuring. The way I see local delivery, and this might other people might see this slightly differently, but I think generally, if we're considering women for local delivery, we generally mean normal delivery at term or as dictated purely by the obstetric situation. And I think once we're starting to move into there being any cardiac or manipulating delivery in some way for cardiac reasons, then we're going to default to delivering in the centre. So if we're saying we think we shouldn't go beyond gestation, or if we think the second stage should be abbreviated, or if we think for cardiac reasons, then that an epidural is, a fairly strong recommendation, then they're the sorts of things that we would not be suggesting local delivery for. And I think overall we have a pretty cautious approach to deciding where women should deliver. So I think we probably only suggest local delivery if we think the cardiac risk is essentially negligible. And if there's any uncertainty or debate about that, then we probably tend to deliver in the tertiary centre. And I suspect we in some ways, if anything, we could probably deliver more people locally. And of course, the confidence, as I've just mentioned, really, the confidence of the local centre in managing patients is important. And that may well just require some discussion with or explanation by the cardiac obstetric team about the individual's condition. If you ask the question, what cardiac lesions are suitable for local delivery, I think that's not necessarily an easy question to answer, because it's a little bit more nuanced than that. And it's not just about a simple list of conditions, and we need to think about patients on an individual basis. But as a general rule, the sorts of things that may well be suitable for local delivery are women with small ventricular septal defects, or small patent ductus arteriosises, if that's the right plural. Many unrepaired atrial septal defects will actually be suitable for local delivery. Certainly mild valve disease, and often up to moderate valve disease, and patients with a background of tetralogy of Fallot who have a good repair. And there'll be others, that's not an exhaustive list. And again, some of those patients may not be suitable. But what, in addition to those sort of general rules, there may be more complex conditions or patients with residual congenital lesions who may still be suitable for local delivery. And so what I've done is I've just looked at our clinic over the past few months and selected 3 cases that I think come into this sort of category. So I'm just going to talk these through. So first patient is a 29-year-old who's born with severe pulmonary stenosis. And that's severe enough to need treatment as a neonate, so treated with a pulmonary valvotomy. So a very narrow pulmonary valve that's opened up to improve the flow through from the right heart to the lungs. And then at the age of 7, I think all of this was in a different centre, but at the age of 7, she has a device closure of a patent foramen ovale. So that's a defect in the atrial septum, and I suspect that's because she was shunting blood from the right heart to the left heart at times. And she is left, as a result of her initial surgery, with severe pulmonary incompetence, so a severely leaking pulmonary valve. And this causes her right ventricle to be mildly dilated, but it functions well. She's in her first pregnancy, she still is. She works in a warehouse, and when we saw her at 21 weeks, she has no cardiac symptoms, and she lives about 30 minutes drive from Leeds General. So for the cardiologists involved or anyone else who's interested, this is her echo. This is the right. I don't know if you can see my cursor, but on the left-hand side, this is the right ventricular outflow tract flowing into the pulmonary arteries, and the red flow you can see going backwards is severe or free pulmonary incompetence. And then on the right, you can see the right ventricle, the left-sided one, as you look at your screen, which is a little bigger than it should be, but it's functioning well. So this is a woman who has a hemodynamically severe lesion. She's got severe pulmonary incompetence. But she's someone who, at the moment, I'm hoping that we're going to plan for a local delivery, provided she's okay when we assess her later in pregnancy. So we'll continue to keep an eye on her, but hopefully plan for local delivery. And the reason for that is that she's obviously asymptomatic with this pulmonary incompetence. She's asymptomatic when she's got the demands of pregnancy as well. And this is a lesion that is often tolerated very well. And I would expect that she would tolerate the additional cardiac demands of labour very well. And she doesn't have a history of arrhythmia, and I think her arrhythmic risk is low. Maybe not zero, but low. And I think all of that means that we'd be happy that her risk is low enough that she should be able to deliver locally. So the second case is a case of repaired total anomalous pulmonary venous drainage. Now, don't worry, I'll tell you what that is. So she's 32, and she was born with this condition, total anomalous pulmonary venous drainage. So just to explain, you can see the diagram on the left of the screen. The normal situation is that blood from the lungs comes back in the pulmonary veins and should drain towards the left atrium. But in her, this did not occur. So there was no connection between the pulmonary veins and the left atrium. So the blood was diverted across to the right side of the heart and came into the right side of the heart, and then it finds its way into the left heart by coming across the atrial septum and then out to the body. So that is a serious and fairly complex congenital cardiac condition and requires early treatment. And she had the standard treatment, which is a surgical reconnection of the pulmonary veins to be connected to the left atrium. And then you take away the connection to the right side of the heart. And she did well, but she was actually lost to follow-up. And she didn't represent until she was pregnant at the age of 27, so about 5 years ago. And at that stage, the repair looked good on echo, and we were happy for her to therefore have a local delivery. She then had a cardiac MRI scan, which, as expected, confirmed that the pulmonary vein, the connection of the pulmonary veins to the left atrium was unobstructed. So one of the things that can occur in this situation is that that connection created as a neonate can be stenosed or smaller than it should be. And if that's the case, then that is not someone we'd be happy to deliver locally. It behaves physiologically like mitral stenosis, and that's someone we'd need to keep a close eye on and not deliver anywhere other than the centre. So this is her next pregnancy now. So we've seen her relatively recently when she was 20 weeks. She remains asymptomatic, and this is her echo, and it shows really nicely. This is her left ventricle at the top. This is her left atrium at the bottom, and you can see this is the pulmonary venous flow coming into the left atrium, and this is widely patent, so blood's getting in there absolutely fine in the middle of pregnancy when there's additional kind of volume load of pregnancy. So we were really happy with her. I didn't feel we needed to see her again in pregnancy, and she was absolutely clear that she wasn't going to have any more children. So in fact, we have discharged her completely from follow-up, because I don't expect this to change over time. And then the third case is someone who has a number of congenital cardiac anomalies. So she's 32, she's currently in her first pregnancy. At the age of 21, she needed heart surgery to close a small ventricular septal defect, and she had a significantly leaky tricuspid valve, so that was repaired, and she also had a PFO closed. She also has, and I'll talk about this in the next slide, anomalous drainage, so I've spelled that wrong, of the right upper pulmonary vein to the SVC. And she also has an interrupted IVC. So the IVC doesn't drain directly into the right atrium. Blood comes around and it drains superiorly into the SVC, and I'll explain that as well. So that's her cardiac background. And then she also has a fairly significant non-cardiac background, in that 5 years ago she had developed bilateral DVTs and large PEs, and she was given this diagnosis of a leukocytoclastic vasculitis, henoch-Schönlein purpura, and had weekly positive lupus anticoagulant. But she recovered well from that, and she's on a lifelong DOAC as a result. So if you look at the headline diagnoses in a clinic letter, there's quite a few lines there and quite a lot that a lot of people would understandably not really understand what it all means. But she's a patient that I hope will be suitable for local delivery. Why do I think that? Well, from a thrombotic history point of view, she's already under the kind of local obstetric haematology team. She's on treatment, dose low molecular weight heparin. I think that clearly can be managed by any unit. And from a cardiac point of view, her heart's in good shape. So she's had surgery. She no longer has a VSD. It was always small and probably wouldn't worry us anyway. The tricuspid regurgitation is now mild, having been operated on. And to be honest, even more significant tricuspid regurgitation we'd expect it to tolerate well, and ventricular function is good. She does, though, have residual congenital cardiac abnormalities. So she has this anomalous pulmonary vein. So this is a picture that illustrates that. So you can see the right upper pulmonary vein, so draining blood from the top of the right lung comes into the SVC, and it should be coming across into the left atrium. And that causes a degree of extra blood flow and volume load from through the right side of the heart. But that's a relatively minor hemodynamic condition, and we'd expect her to tolerate pregnancy well from that point of view. And then she has this interrupted IVC, which sounds a bit concerning, really, doesn't it? But it's not. This isn't quite exactly how hers is in this picture here. But the IVC gets up, in her case, just below the kidneys. It stops, and it does not drain directly into the right atrium. But the blood just finds its way into the right side of the heart by heading up the azygos vein and draining into the SVC. So ultimately, it gets to where it needs to get to, and that has no physiological consequence for her or for her pregnancy. So I think the summary of that is that, of course, congenital heart disease will be unfamiliar to most non-cardiologists, and frankly to a lot of cardiologists as well, and it can sound very complex, and it indeed may well be complex. But often lesions or residual lesions after repair are mild, and the risk in pregnancy and for around delivery time is negligible. And the risks still can be very low in those with more complex conditions, particularly once they've been repaired, and even in those who have hemodynamically severe residual lesions, such as that patient with pulmonary incompetence. And so it's very much a case-by-case basis about what the condition is, its severity, symptoms, etc., about whether local delivery might be appropriate. And obviously that's then a discussion with the local team about whether that's felt to be an appropriate course of management. And that's my lot.
Great, thanks so much, James. Are there any questions? There's nothing in the chat at the moment, and I can't see any hands up, so we could move swiftly on. I see Justina. Go ahead.
Yes, thank you, James. So I have a couple, if not 3 questions regarding the first case specifically. So, so we have previous pulmonary stenosis, pulmonary valvotomy, and severe pulmonary regurgitation. And I understand that this patient was lost to follow up, but I just wonder if you had such a patient and you would have them for pre-conception counseling, would you do any additional tests like MRI for the assessment of the right ventricle and or exercise test? And my second question is, so because you said before on your first slides regarding referral and delivery planning, that any patient that would that you would only recommend local delivery if it's term delivery. So in this particular patient, when they have severe PR and the degree of the RV dilatation, would you recommend induction of labor around like 39 weeks, or would that be term delivery that you wouldn't induce?
So I think from the point of view of assessment. I think that one wasn't lost to follow up actually, but you'll be aware our standard assessment is to assess the RV, is to perform cardiac MRI and all that sort of stuff. So yeah, you'd like to have had that up to date. Although if it's to be honest, and if it's a few years old in her case, in a case like that, and we know on echo that the right ventricle is very much in keeping with the previous assessment, then I wouldn't particularly feel I need another one, to be honest. Exercise testing, I wouldn't automatically do if she's someone who clearly has no symptoms and does regular exercise and she's absolutely fine with that. Then I'd be relatively happy with that, to be honest. And I've forgotten the second element of the question.
About the delivery planning in terms of the timing, whether you would recommend induction, specifically that you said that they can deliver locally, but previously you said that if you recommend local delivery, that would be rather term delivery. So just whether you're happy with the local center to induce and whether you would recommend induction in this case.
So in her case, provided we're happy with her when we see her at around 36 weeks or something like that, then I wouldn't be suggesting. I would be happy with the obstetricians to manage that. So if she's going, I wouldn't suggest that she's induced by a certain particular time, I don't think. And if just manage post-term delivery as would be normal during, for obstetric reasons, in that particular case.
Okay, thank you.
You might disagree, Justine.
No, it's just like, it's in a way a bit tricky because exactly as you say, like it's very well, patient, sorry, Julie, I will call you in a second. Patient that is, very well compensated and the good RV function. It's just that sometimes we probably tend to, any specifically, like with this degree of the leak, I would say that more I can comment as well, but I think we would be tempted to recommend induction of labor at the 39 weeks following TRTP guidelines that with any patients with heart disease, that this recommendation to deliver them before 40 weeks. But this is very debatable, and as you say, that's the patient that has a actually good RV and. But you can also comment what you would know in this case?
Yeah, no, I mean, I think that's an understandable argument. It's something we discuss quite a lot in the clinic. In that particular case, I wouldn't particularly feel we needed to recommend it, but I'm perfectly happy to think that others might.
No, I understand.
I'm just going to move because I'm about to run out of battery, so apologies. I am listening. I get my charger.
I think we'll take a question from Ken and then Thomas quickly as well.
So just more of a sort of pointer observation, I guess, is that oftentimes we sort of say that patients can deliver locally, but when we sort of talk to the local teams, it's often the anaesthetists actually that kind of push back on that and say, actually, no, we're not happy to have this patient, even though you think she's low risk, delivering here. So oftentimes we do end up sort of just delivering the patients that are lower risk who potentially could deliver locally, but just because of sort of anxiety, I guess, more from the anaesthetic side of things normally. And with that in mind, sometimes we do, because of our geographical area that we cover, sort of bring them in around 39 weeks and induce them just more to sort of give them a time and place for delivery, if you see what I mean, rather than having to sort of dash over from Carlisle or something in labour. So some of our sort of planned induction is to sort of mitigate against that.
Absolutely, I think we do exactly the same, Ken. And I think if there is clear anxiety in local teams, then I think really that's kind of almost what I was referring to earlier in that initial slide, is if there's any doubt, then the default is to deliver in Leeds, and I'm sure it is in Newcastle.
Great, thank you. Thomas, did you have something quickly to add there?
Very briefly, just to build on that, in general pregnancy, there is almost a benefit from inducing between 39 and 40 weeks at a clinical level. for maternal and fetal outcomes in a well population and various sort of hypertensive and other populations. So it comes very much down to sort of a service delivery and patient preference as well, and those discussions about whether they want to go through an induction process and the practicalities we've outlined. And just to pick up on Ken's point, we have the don't want to malign the anaesthetist, but it's often the anaesthetist pushing back from other units. I think one of the strengths of this meeting and the framework that Caroline's outlined, one of the strengths of the framework of the maternal medicine centres and networks is that there is an agreed structure, there's an agreed classification, and what needs to be delivered in a maternal medicine centre and what can be dealt with locally. And I think one of those discussions is, although you may not be familiar with the situation, you know, having that, what is it that makes you nervous about this? Because actually the national framework would suggest delivery in your unit is suitable. I think you know, having that framework is really important and useful to be able to open up those discussions with the local teams when the obstetricians, the cardiologists are happy with the anaesthetists. You know, having that question, what is it that means that you can't support this nationally, this national framework?
Right. Thanks, Thomas. We'll move swiftly on because we are slightly over. So next up we have Deepa and Simon, who are both from Newcastle, I think. Deepa, is that correct? Now you can do your introductions, but talk about valvular heart disease.
Can you see my screen there? Yes.
Yes, I can. Yeah, if you just do it on present, that's smashing.
Yeah, that's lovely. So hi everybody. It's a pleasure to talk about a case that we encountered in Newcastle. I'm just going to use this case to sort of illustrate a few points that we've spoken about already. But you know, feel free to put any questions in the chat or at the end of the presentation. So this lady was a 38-year-old lady. She'd had 5 previous pregnancies. Initially had 3 vaginal births and then had 2 cesarean sections. All her pregnancies had been uneventful except for her second pregnancy, around which she had a PE around 2 months gestation. When we saw her, she had slightly elevated BMI of 31 and she was a smoker. So she presented to her local hospital, which was a district general hospital, around 18 weeks gestation during her 6th pregnancy. And rightly so, there was a high suspicion of pulmonary embolism, particularly with a history of PE during her second previous pregnancy. So she had a CTPA, which ruled out a pulmonary embolus. However, they saw that she had bilateral pleural effusions. And then the next day she had an echo done at the local hospital, which showed severe mitral regurgitation. She was then referred to the regional maternal medicine MDT, and then shortly after we discussed her, we arranged to see her urgently in the combined obstetric cardiac clinic 2 days later in the tertiary centre. So when we saw her clinically, she was very breathless on exertion. She had orthopnea, she had palpitations, her JVP was mildly raised and she had a pansystolic murmur. On ECG, she was in sinus rhythm, and an echocardiogram, which I'll show you a few pictures of, showed that on top of having severe mitral regurgitation, she also had severe mitral stenosis with a very abnormal mitral valve. In fact, the posterior leaflet was very thickened and tethered, and although her LV was mildly dilated, her systolic function was preserved. So just very briefly show you some echo images. You can see that her anterior mitral valve leaflet here has a slight rheumatic appearance to it, but also the posterior leaflet seems to be very tethered. And as a result of this, there is sort of a coaptation gap here. And in combination, this is causing severe mitral stenosis and severe mitral regurgitation. You can see this is a cross section across the mitral valve, and again, very thickened leaflet with reduced mobility. And as I mentioned, although she had significant valvular issues, the LV function luckily was still preserved, as well as her right ventricular function, and there was no significant tricuspid regurgitation and no sort of significant signs of pulmonary hypertension on echo. The mean gradient across the valve was 13.6, so anything above 10 we would consider severe mitral stenosis. So this is her echo findings. So our impression is that this was a lady who was now 24 weeks gestation into her 6th pregnancy. She had severe mixed mitral valve disease. The etiology we were slightly unsure of. We thought, probably it was rheumatic, but it could also be a congenital abnormality of the mitral valve with kind of abnormal papillary muscle. So in terms of an immediate management plan, we're quite lucky to have dentists assigned to our combined clinic, and this lady had very poor dentition. We're quite concerned about the risk of infective endocarditis given the abnormal mitral valve. So she had a dental assessment, dental plan in clinic, and we admitted her to the antenatal ward. We started initially an oral dose of furosemide, just 40 once a day, and a small dose of bisoprolol, 1.25. Now, in terms of anticoagulation, because of her previous history of PE, but also the severe mitral stenosis, we were worried about the risk of thrombus formation, and we put her on therapeutic tenzaparin, 14,000 units. Her admission bloods showed that her HB was 102. Her NT-proBNP was mildly raised at 401. Now, we feel that NT-proBNP can be quite a useful tool to use, because this lady, as you remember, presented with with breathlessness symptoms with a negative CTPA. However, because of a mildly raised NT-proBNP and bilateral pleural effusions, she was able to have an echo in a timely fashion. So, normal NT-proBNP can help you sort of, guide you as to whether someone with breathlessness is purely physiological because of pregnancy, or is this someone that you need to consider an echo on. And actually, this lady, after she had furosemide and a bit of bisoprolol, she felt better symptomatically. She was discharged 5 days after her admission with weekly follow-up. And unfortunately, when we saw her again in clinic a week later, she was more symptomatic. She was now in NYHA class 3. She had worsening MR on echo, and therefore the decision was made to readmit her to hospital. And this time she had intravenous furosemide, higher dose, 40 twice a day. Bed rest was recommended in view of her symptoms, and actually she did improve with the IV diuretics, and again she was discharged 5 days later, again with a closed clinic follow-up appointment. And actually, when we repeated her echo 4 weeks later, there was an improvement in the degree of mitral stenosis with offloading her with diuretics and with a bit of beta blocker. So now her mitral stenosis was being graded as moderate with a mean gradient of 8 from 13. So significant reduction after beta blockade and diuresis. And we had a long discussion with her as to the delivery plan. Now, you could argue that because she had moderate mitral stenosis, that vaginal delivery could have been an option for her. However, this lady had 2 recent cesarean sections, and we felt that induction of labour for her might be higher risk and may not be a viable option. And it was her own personal preference to have another C-section as well, with bilateral tubal ligation at the time of the procedure. And we decided that she would have a planned preterm delivery, and the 4 weeks kind of was decided because we felt that in terms of the neonatal risk, this was not much different compared to 36 and 38 weeks, as long as mum was okay. So she was admitted to the antenatal ward sort of 33 plus 6 days. She received IM betamethasone to reduce the risk of respiratory morbidity in the baby. And there was a very clear, detailed delivery plan, arterial line to invasively manage her blood pressure during delivery. A combined spinal epidural was felt less likely to cause rapid drop in blood pressure. So this is what was recommended for her. And actually, she had a very uncomplicated procedure, including tubal ligation. Now, in terms of the 3rd stage of delivery, as per NICE guidelines, women who were in dual class 3 or 4, which I'll go on to talk a little bit more detail later, it is recommended that actually they should have a slow IV bolus of diluted oxytocin to avoid any sudden hemodynamic change. Particularly for her, we were worried that any sudden change in the gradient across the valve could precipitate heart failure. So this was recommended, and also the recommendation is that ergometrin should be avoided, again, to reduce the risk of hypertension-induced heart failure. And actually, her delivery went very well. We made sure that there was an HDU bed available for her just in case, but she didn't require the bed, but she obtained one-to-one care in the delivery suite for the first 24 hours, and she was ready for discharge day 3. We discharged her on the bisoprolol and oral furosemide, and also a 6 weeks course of therapeutic tenzaparin to mitigate any VTE risks in her, especially given the history, high BMI, and history of smoking. Unfortunately, she didn't attend her combined obstetric cardiac appointment postpartum, but we arranged follow-up locally with obstetrics and with also her cardiologist with a repeat echo after. So some of the sort of discussion points from this case is, first of all, this was a lady who was undiagnosed prior to her 6th pregnancy with mitral stenosis. So she'd had 5 successful pregnancies previously. And when she did present to her local district general hospital, she got a CTPA as a first investigation, as there was high suspicion of PE, rightly so because of a previous history. However, it was rightly picked up that, you know, given a normal CTPA, she had a mild elevated NT-proBNP, she had bilateral pleural effusions, therefore an echo was done in a very timely fashion the next day. And once the significant valvular problem was picked up on echo, she was referred again in a timely way to the maternal MDT and then seen in a combined clinic. So I think this was a very sort of positive points from the case that we reflected on. And in general, we know that moderate and severe mitral stenosis is very poorly tolerated in pregnancy. This is because the increased cardiac output can increase the gradient across the valve, and there's an increased risk of heart failure, which can cause maternal and fetal complications. And as per the recommended guidelines, her care was sort of taken over in the tertiary centre as from then, including her delivery. The other thing that I wanted to mention is in terms of echo assessment of the mitral stenosis, this can sometimes be very tricky in pregnancy because measurements such as mean gradients and pressure half time can be less reliable, because these measurements can be increased just because of the fact that the patient's pregnant, because of tachycardia, because of anemia and a high output state. Therefore, sometimes other parameters such as direct planimetry may be needed to kind of accurately assess the degree of mitral stenosis in these patients. So this patient was clearly initially on presentation in the WHO criteria 4, where she was extremely high risk of maternal mortality and morbidity. And this is sort of our risk stratification for the maternal medicine centre referral. And again, she was in the category C criteria, where she had moderate to severe mitral stenosis here. So in terms of maternal risk for this patient, we discussed that the risk of decompensation was fairly high for her, given her initial presentation of severe mitral stenosis. And in fact, heart failure frequently happens in patients whose valve area is less than 1.5. So anybody with moderate to severe mitral stenosis, and particularly during the 2nd and 3rd trimesters. Pulmonary edema can also be precipitated by atrial fibrillation. So mitral stenosis patients in about sort of 10 to 15% cases can cause atrial fibrillation. And also atrial fibrillation carries the risk of causing blood to swell around the left atrium, which can cause a left atrial thrombus, again, which causes additional risk of thromboembolism. Mortality tends to be between 0 to 3%, which is mainly related to acute heart failure during or after delivery. And in this lady, there were a few risk factors of maternal predictors of neonatal events. So at baseline, NYHA class was more than 2. She had left-sided heart obstruction and she smoked. So again, she was a high-risk patient in terms of risk to the fetus as well. And in terms of risk to baby of mitral stenosis, we know that there's high prematurity rates up to 1/3. And there's also a risk of intrauterine growth retardation and stillbirth. And offspring risk tends to be higher in women with higher NYHA class during pregnancy. In terms of managing these patients, as I mentioned already, thorough echo assessment is crucial. In borderline cases where the echo data might not match up, you can use exercise testing and exercise echo to see if the patients are symptomatic and to assess the degree of stenosis a little bit better. Pre-pregnancy counselling is really, really important. So as per the ESC guidelines, if this patient had presented in the 1st trimester, then she should have had a discussion about whether termination of pregnancy could be an option for her, given the significant risk. So all patients with moderate or severe mitral stenosis, even when they're asymptomatic, should be counselled. And if they want to go ahead with the pregnancy, then we need to consider whether percutaneous intervention to the mitral valve is indicated in severe mitral stenosis. I'll go on to talk a little bit more about that in the next slide. and then regular clinical and echo follow-up depending on the hemodynamic tolerability of the lesion. In terms of red flag symptoms, so if you see someone with mild or moderate mitral stenosis, and if you see any of these, then they warrant a very urgent, sort of more urgent referral and urgent discussion about whether place of care and further intervention is required. So if anybody has worsening NYHA class, if they have worsening ventricular function, if the pulmonary pressures appear to be rising, or their BNP, or if there's any symptoms of endocarditis or thrombus, then again, this is something that we would be worried about. In terms of medical therapy for these patients, so when they have symptoms, breathlessness, or when they have pulmonary hypertension on echo, which is when the pulmonary pressure is more than 50, then bed rest is advised, as well as beta blockers. Diuretics we use, however, we try to avoid high doses to reduce the risk of ototoxicity to the fetus. However, most patients seem to have symptomatic benefit from diuretics, from beta blockers. Really important therapeutic anticoagulation is recommended if they have any evidence of atrial fibrillation or concerns about a left atrial thrombus, if they've had a previous PE, as which this lady had, or anybody with moderate to severe mitral stenosis and a large left atrium, low cardiac output, or any signs of heart failure, again, would recommend to put them on therapeutic anticoagulation as per the ESC guidelines. In terms of interventional options, so these don't get done very frequently in pregnancy. However, if they were to be considered, then we tend to do them in the second trimester. Although there is no good evidence that general anaesthetic is teratogenic, mostly we feel more comfortable sort of offering these procedures, especially if that involve a lot of radiation risk after 20 weeks gestation. And percutaneous mitral commissurotomy is reserved for those in NYHA class 3 or 4, and or evidence of pulmonary hypertension in the absence of any contraindications. It needs to be done in an experienced centre, and also consider shielding, lead shielding to reduce radiation dose to the fetus, as well as, screening, less screening time during the procedure. Open heart surgery is only reserved for cases in which all other measures fail and in which the mother's life is threatened. But again, something that doesn't happen very often. Usually most patients tend to be managed with diuretics and bisoprolol and sort of planned preterm delivery. It's just a brief summary of PMC, but essentially a balloon is used to stretch the mitral valve here. Now, there's very specific criteria for doing this procedure. So if the valve is very calcified, for example, or if there's significant regurgitation, you could make the regurg worse. So the patient selection for this procedure is really, really crucial. And discussion with the MDT of whether the interventionalist doing the procedure is really important. In terms of delivery options, so vaginal delivery can be done in those with mild mitral stenosis or even moderate or severe mitral stenosis who are in NYHA class 1 or 2 without pulmonary hypertension. However, if there is moderate or severe mitral stenosis in someone who's very symptomatic, so in NYHA class 3 or 4, or have pulmonary hypertension, then a caesarean section would be more likely to be recommended. However, again, this is something that should be discussed on a sort of patient-to-patient basis. Caesarean section is recommended in those who with very severe mitral stenosis in whom PMC couldn't be performed or has failed. So this is just a very quick summary of ESC guidelines in mitral stenosis, and it's sort of what we've discussed already. And you can see that therapeutic anticoagulation again goes on there in case of atrial fibrillation, thrombosis, or prior embolism. That was just a very quick run through the case. I wondered if anybody had any questions.
Thanks, Deepa. We're running a bit late, but there was just one. Did this patient have an echo in her previous pregnancies at all?
No, she didn't, because I think I haven't got the details of her second pregnancy presentation where they did a CTPA and whether she was investigated after that or not. But no, she's never had an echo before. And as far as I can see, there's no documented murmurs or anything. And to be honest, it can be quite difficult to listen to the murmur of mitral stenosis in a lot of cases. And it could be that, being pregnant accentuated the murmur, which is why they could hear it in this pregnancy. But no, there was no kind of documentation of prior echoes.
Great. Thanks, Deepa. We'll swiftly move on to Kate, and there is a question in the chat, Deepa, if you would like to answer that. But if we can move on to Kate, that'd be good.
Yeah.
Kate, you're on mute if you're talking.
Yes, I just realised that. I was trying to.
We can see the slides, but if you want to do a
Lovely.
presentation mode, that'd be
Excellent. I'm just trying to put them back up to where they were. Excellent.
brilliant.
So good afternoon, everyone. I'm Kate Gatenby. I'm a consultant cardiologist and I work in Leeds. And I'm going to talk a bit about ischemic heart disease. And although I will talk a little bit about the management of acute problems with ischemic heart disease in pregnancy, actually what I'm really going to focus on is risk assessing women who have known previous ischemic heart disease, because I think that's a problem that we're seeing increasing amounts of. Certainly in Leeds, it is something that is happening with increasing regularity. For some reason, my slides are not moving on. There we go. So I'm going to talk about a lady who we looked after recently, a 41-year-old lady who was parida 3, gravida 2. She'd had one spontaneous vaginal delivery and then a second one a few years prior to this, where she'd been induced at 38 weeks because of maternal hypertension. She was diabetic, so even after her second pregnancy was diabetic with an HbA1c of 56, not a smoker, but did have a high BMI and was dyslipidemic. 2 years ago, so actually after her last pregnancy, she'd had a non-STEMI where she ended up having a percutaneous intervention to her circumflex vessel. This was atheromatous coronary pathology, so standard coronary artery disease, not SCAD, not thrombosis. And she was known to have some moderate residual atheroma, but she had normal left ventricular function. And she presented to her local hospital when she was 13 weeks pregnant. She'd had some burning chest pain with eating for the last 4 weeks. Occasionally it was coming on with exertion, but was definitely different in character to her previous myocardial infarction. She was reviewed in her local centre and was promptly referred to us to the obstetric cardiac clinic in Leeds for further evaluation. So why are women with ischemic heart disease sort of at risk? Well, we know that pregnancy itself, even in women who haven't had previous ischemic heart disease or coronary artery disease, is associated with an increased risk of myocardial infarction. And whilst a lot of that will be related to SCAD or MIs with normal coronary artery, we are seeing an increasing number of women who are becoming pregnant at a later age with increasing multimorbidity, so lots of diabetes, lots of hypertension, lots of dyslipidemia and obesity actually, which increases the risk of developing sort of pre-existing coronary artery disease. Obviously, combined with that, we're seeing an increasing number of women having late pregnancies with fertility treatments. So I think it is something that we need to be aware of. We know that the reported maternal outcomes for women with pre-existing coronary disease are quite poor. If you look in the ESC guidance, the data that's quoted is anywhere between 0 and 23% of serious maternal cardiac problems during pregnancy in those who've got pre-existing coronary artery disease. But it's still not something that we know an awful lot about. Combined with the maternal risk, we know that women who've got existing ischemic heart disease have increased risk of fetal or neonatal events. And I think that's almost certainly because of the combination of cardiovascular risk factors that these women carry with them that mean that not only is their heart at risk, but they get poor placentation, they're at risk of developing preeclampsia and gestational diabetes. So these really are sort of multi-morbid women usually. If you were to see someone who was thinking about becoming pregnant who had known ischemic heart disease, or indeed if you saw someone early on in pregnancy with ischemic heart disease, these are the type of things that I would think about. I would wonder whether or not there'd been a myocardial infarction in the past, and if so, when. And that's because we know that ideally pregnancy should be delayed for at least a year after a myocardial infarction. And one of the things that we've done in Leeds recently is to try and ensure that all women of childbearing age who have myocardial infarctions have some contraceptive advice built into their cardiac rehabilitation. Aside from knowing what their coronary artery disease is like, I would also want to know what their left ventricular function is, because obviously if someone has had a large anterior myocardial infarction, then not only are we dealing with coronary artery disease, but we're potentially dealing with a heart failure syndrome. You want to have some appreciation about whether this is stable, minimal atheroma, or whether this is someone who has significant ongoing ischemia.
I've already mentioned the associated comorbidities. Their obstetric risk, because I think that's important. If someone has previously had small deliveries, increasing hypertension during previous pregnancies, then that in itself might play into their risk of having further cardiac problems during this pregnancy. And you will also want to think about what medications they are taking. And so for this lady, we actually saw her when she was 13 weeks pregnant. Her myocardial infarction was more than 12 months ago. She'd had a stent to a circumflex with a drug-eluting stent, and we knew that she had some moderate non-flow obstructive atheroma in other vessels. So technically shouldn't be getting any ischemia. She had normal left ventricular function and she was a non-smoker. So it's really important, obviously, that we're giving women advice about smoking cessation. She was taking metformin and aspirin. Her statin had been stopped at a local hospital and she was using GTN on a PRN basis. She had chest pain, but that chest pain was really atypical. And women with coronary artery disease don't get different chest pain if they're having ischemia in pregnancy. They usually get fairly typical ischemia. But I didn't think when we saw her in clinic that this was likely to be ischemic pain. She certainly hadn't had any evidence of any troponin rises and she had a normal ECG. But she did have some cardiovascular comorbidity. So there were some things here that made me nervous. She was diabetic, she was hyperlipidemic, and she had a high BMI. And she had had those prior obstetric complications. She's had some previous maternal hypertension and needed an induction of labour because of her baby being a bit small. So all in all, we felt that this was a relatively high risk case. And certainly we felt she mandated some review in the combined obstetric cardiac clinic, even if we didn't think, even if we didn't come to the conclusion that delivery with us was necessary. So how are we going to look at this in a little bit more detail? Well, it's really important if you've got women who've got atheromatous coronary disease, who've got chest pain, that you do have some idea about whether or not they have any associated ischemia. And there are ways that you can do that even in pregnancy. So we did a stress echo for her. So an exercise stress echo without any contrast. And she managed to exercise for 6 minutes on a Bruce protocol that didn't replicate any of her chest pain. She didn't get any ischemic changes on her ECG. She had good left ventricular function and didn't develop any regional wall motion abnormalities. And I think stress echoes in these women is a really useful thing to do. You get an idea about LV function, you understand whether they're getting any ischemia at high heart rates, and you also understand what the magnitude of that ischemia is so that you can have an appreciation about how you're going to manage it during pregnancy. Actually, we thought that her chest pain was likely to be gastric. She had a proton pump inhibitor and we started her on her beta blocker. So she hadn't had a beta blocker prior to pregnancy, but we thought a beta blocker was necessary. And actually, we did see her fairly regularly, predominantly because the combination of risk factors and the previous ischemic heart disease made us feel like our clinic was the best place for her to be monitored during pregnancy. Her beta blocker was increased. We ended up giving her a little bit of nifedipine because her blood pressure started to tick up. Probably not at a level where you might otherwise have treated her hypertension, but the combination of factors made us feel like we should try and achieve normotension for this lady. She actually was iron deficient as well, so we arranged for her to have some iron because we know that obviously ischemia is a supply-demand problem. If you're iron deficient, you're going to get ischemic at lower heart rates. So we felt like giving her some intravenous iron, given that her ferritin was low, was the right thing to do. Just to run through some of the things that might make you worried about a woman if you were assessing her regularly during pregnancy and you know she has ischemic heart disease, or alternatively someone who presents de novo during pregnancy. These are the red flag symptoms that come up on the Embrace report. But essentially, if you have chest pain that's requiring opiate analgesia, if you're having repeated presentations with chest pain, as I said, if you have ischemic sounding chest pain is very often ischemic. And if you have chest pain in patients who you know are at high risk of ischemic heart disease, whether that's just by virtue of the combination of risk factors that they have, or whether it's because you already know they have ischemic heart disease, they're obviously red flags and should be taken very seriously. When it comes to thinking about acute coronary syndromes in pregnancy, even though I've talked a lot about sort of atheromatous disease, it's not uncommon that a presentation with acute coronary syndrome would actually be something like a spontaneous coronary artery dissection. Acute coronary syndromes are most common in the 3rd trimester of pregnancy or postpartum. They present in the same way that an MI presents. You get chest pain with ECG changes and an elevation in cardiac troponin. So troponin should be normal during pregnancy. You can use it in the same way as you can in a non-pregnant woman. And I know that previously on the chat there was a question about BNP, and BNPs should be normal in pregnancy as well. So the biomarkers that we use to assess women outside of pregnancy can be used in pregnancy as well. And chest pain with ECG changes and an elevation in cardiac troponin can either be atherosclerotic disease, it could be spontaneous coronary artery dissection, or you could have someone who's presenting with an MI with normal coronary arteries. For the women who present with acute coronary syndromes during pregnancy, there's just some different images of the type of pathology you might see, where the image on the top left is an atheromatous coronary plaque, and the image on the bottom left is a dissection, and the pathologies are slightly different, and the way we might treat them if a woman came to angiography would be different. But the point here being that actually, if you had an acute coronary syndrome during pregnancy, you should manage them really in very much the same way that you should manage a non-pregnant woman. Aspirin, morphine and nitrates are all things that can be used during pregnancy. And if there is a patient who has ST elevation myocardial infarction presenting with chest pain, then actually the best way of treating that is with an emergency primary PCI. For some of those women, you might want to give them dual antiplatelet therapy. Obviously, you need senior obstetric input. And then there are considerations about what you might actually do with the blood vessel, depending on whether it's a spontaneous coronary artery dissection or whether it's an atheromatous plaque rupture. And ideally, if someone presents with an acute coronary syndrome in pregnancy, you would want to try and, well, there isn't anything you can do to delay deliveries, but if you thought that someone was going to need to deliver within the next 2 weeks, then that might be the time that you would think about cesarean section. But generally speaking, even after an acute coronary syndrome, a preferred method of delivery for most women will be a vaginal delivery. So how did we manage this lady? Well, we remembered that anemia and volume depletion may have exacerbated her ischemia. We wanted to try and make sure that she wasn't overly hypotensive, although actually I think some of this, given that we knew that she didn't have significant residual ischemia on a treadmill, was probably a little bit overkill. What is important is that you are aggressively treating any hypertension that coexists. And as I've already said, there isn't really any evidence to suggest that a caesarean section is associated with improved outcomes in these women. And so our usual strategy would be a vaginal delivery. Very often we would suggest an early epidural to try and reduce tachycardia. And as has already been mentioned, anything that suddenly increases your afterload, so ergotamine or bolus IV syntocin, would be something that we might often suggest to avoid. And this woman actually delivered at her local hospital, which was a big hospital, very easy, very able to deal with any cardiac complications if any arose. But we thought that really the risk of anything happening for this woman during pregnancy was fairly low. In terms of postnatal considerations, you'll see this slide a lot from me because I'm going to show it for all of the talks that I give, because I think the 4th trimester for a woman with cardiac disease is really important. Particularly for women who have got atheromatous coronary disease with risk factors. This is a really opportune moment to be able to try and improve risk factors, or at least ensure they get some adequate follow-up. So thinking about making sure they're not smoking, getting them back on medical therapy, restarting statins if necessary, having a think about what medication they are able to take if they're going to breastfeed, educating them about the risk of subsequent pregnancies or fertility treatment, and then obviously being able to talk to those women about contraception as well is really important. And I think that's something that we try and do with all of these women who've had pregnancies, and we do offer them appointments in our clinic after they've had their delivery so that they can talk about these things, or alternatively we'll give plans to local units to try and help them risk factor optimize their patients just for the future going forwards. And that's me, I think, or at least for this talk. I'll stop sharing my screen.
Great, wonderful, thanks Kate. There's one quick question. Would you continue statins in pregnancy in women with dyslipidemia?
So we've tended not to, but Tom, you'll correct me if I'm wrong. There are some times when, if they're very, very high risk, you might want to have a discussion about it, but we've tended not to continue their statins in pregnancy.
I mean, we've got Ken on here, who is certainly our resident
He's got his hands
expert.
up here.
But I think if there is a good cardiac reason, I tend to continue them. Yeah. But over to you, Ken.
Yeah, I mean, there isn't strong evidence that statins cause a particular problem. And I guess, particularly if they're after the third trimester, it would be reasonable to continue statin, particularly for patients with ischemic heart disease and recent myocardial infarction. The other sort of agents that you can use and have been used for patients with things like hypertriglyceridemia and those metabolic triglyceridemias is benzofibrates.
Wonderful. Thanks, Ken. I think that's all for now. We can move on, I think, to Pamela, who is from James Cook University Hospital in South Tees, who's talking about hypertrophic cardiomyopathy. You okay, Pamela?
Yeah, that's right, thanks. And I've got Deepika Manini with me, who is the obstetrician, and we jointly do the cardio obstetric clinic here at James Cook. Okay, I'll just load the presentation. Can everyone see that?
Yeah, that's great. Thanks, Pamela.
Okay, so I'm talking about hypertrophic cardiomyopathy in pregnancy. Hypertrophic cardiomyopathy is obviously a thickened heart muscle, and the definition is a thickened heart muscle greater than 15 millimeters. It's usually a sarcomeric gene mutation causing it, and it's autosomal dominant, which means that it's got 50% chance of inheritance. It affects about 1 in 500 of the general population, but about less than 1 in 1,000 of the pregnant population. So the case that we're talking about here is Miss S, who has a family history of hypertrophic cardiomyopathy. Her father had a sudden death at the age of 50, so she has an ICD in situ. She personally has hypertrophic cardiomyopathy and has a implantable cardiac defibrillator in situ, and she's 16 weeks pregnant, but she's had a previous spontaneous vaginal delivery at 39 weeks with no complications, and she's NYHA class 1, sorry, not WHO, NYHA class 1, which means that she's not breathless. Her echocardiogram demonstrates normal left ventricular function with no left ventricular outflow tract obstruction. So when you're thinking about somebody with hypertrophic cardiomyopathy, what are the issues, or what do we need to think about? So this is an echocardiogram of this patient. You can see that she has a really thickened interventricular septum here on the echo. And this is the mitral valve here. And you can see that when the heart contracts, so when it's in systole, the mitral valve moves forward and basically causes a left ventricular outflow tract obstruction. So what that means is that there is increased flow through there, and that can cause obstruction, and that can cause symptoms of breathlessness. This is her echo seen in a different view, so seen with this is the left ventricle here, and this is the septum, which is thickened here, and then this is the mitral valve again, and you can see that kind of bends forward towards the septum when the heart is in systole, so when the heart's contracting. And the issue here is when your heart muscle is thickened like this, is that your left ventricular cavity, so your heart cavity, is can be smaller, so there's less space to fill up with blood, and also it doesn't relax as well, so it can become stiff. And the relaxation part of the heart is known as diastole. And so when it's during diastole that the heart relaxes and fills up with fluid. And when you have less time when your heart's stiffer, it needs longer to relax and fill up with fluid. And if you don't have if you have a stiff heart, then that increases your risk of having breathlessness or having heart failure symptoms or being fluid overloaded. And this can lead, like I said, to left ventricular outflow tract obstruction. So you can see this on this Doppler here, that the velocity through the left ventricular outflow tract, which is this bit here where the aortic valve is nearly 6 meters per second. So if this was another reason for outflow tract obstruction, for example, aortic stenosis, we would say that this is is severe. And left ventricular outflow tract obstruction is anything above 30 millimeters of mercury, although 50 millimeters of mercury is the accepted threshold for intervention. And this can cause symptoms of breathlessness, and sometimes it can make people feel lightheaded, especially when they exert themselves or even black out. One of the other issues with hypertrophic cardiomyopathy is when the heart muscle gets thicker, it can have areas of fibrosis, so areas where scar tissue forms, and this is seen here on the MRI scan here in the septum, and that gives a substrate or a risk of having life-threatening heart rhythm problems, which is why people with hypertrophic cardiomyopathy can have cardiac arrest or have life-threatening heart rhythms like VT or VF. And it's why often they need an ICD or a defibrillator implanting. So when you have hypertrophic cardiomyopathy, like I said, you are at risk of having life-threatening heart rhythm problems. You're also at risk of atrial fibrillation, and atrial fibrillation can cause fast heartbeats, and that's generally not well tolerated by people with hypertrophic cardiomyopathy because, as I said earlier, they need the period of diastole. They need to have a long diastolic period for the heart to fill up to help prevent having symptoms of heart failure or breathlessness. So when people have hypertrophic cardiomyopathy, the overall pregnancy risk, the maternal mortality risk is low, but about a third end up having worsening symptoms of breathlessness, fluid overload, chest pain, palpitations, blacking out, syncope. And the chest pain side of it is often because the heart muscle is so thickened and hypertrophied that you get a supply-demand mismatch, and it's not because of narrowed coronary arteries, it's because the coronary arteries there aren't able to supply the thickened heart muscle. And there's about a quarter risk of premature birth. So when you're considering pre-pregnancy counselling, you need to find out their personal history and their NYHA class, so how breathless they are, whether they have any history of palpitations or syncope or chest pain. Obviously, you need to find out what drugs they're on. Maybe they'll be on a beta blocker, calcium channel blocker, disopyramide or mavacamten, and they may well be on diuretics. Beta blockers and calcium channel blockers, such as verapamil, can be used in pregnancy. Disopyramide is not really recommended because it can cause uterine contractions, and mavacamten is not. Mavacamten is a new drug, and it's not suitable to be given during pregnancy. The European Society of Cardiology have a risk calculator, and this is your risk of sudden death when you've got hypertrophic cardiomyopathy. And depending on this, they give a recommendation of whether people should have a defibrillator fitted. It's always worth remembering that often when people are pregnant, this can be, or considering pregnancy, this is the first time that they can present to cardiology. So they might have some distant family history, or maybe their dad has a family history of hypertrophic cardiomyopathy, but they just don't, they haven't considered it, or they haven't had screening before. In terms of genetic counselling, it is a genetic condition, and so people have to consider that when they think about getting pregnant, is a risk that their child might be born with hypertrophic cardiomyopathy as well. You need to do assessment of heart rhythm, including whether they are in atrial fibrillation, such as or sinus rhythm. People who are in atrial fibrillation, there's a recommendation that they are anticoagulated, and then they need an echo to look for to look at their heart function and to look at the left ventricular outflow tract gradient. You can also do an exercise test, so you can do a bicycle echo where they cycle and see if there's a provocable left ventricular outflow tract obstruction. So what that means is that when they exert themselves, whether they have increased outflow tract obstruction. So, sorry, I think I've I've completely converted NYHA class to WHO class when I did this presentation, but people who are NYHA class 2 should be seen each trimester, and people who are more breathless should be seen monthly or bi-monthly and have an echo each trimester. And like I said, there's some drugs, beta blockers and calcium channel blockers, which are okay to use in pregnancy, but disopyramide probably not, and definitely not mavacamten, which is this newer drug. People who are in atrial fibrillation need to have therapeutic anticoagulation. DC cardioversion is okay, but you need to have fetal monitoring throughout it for people who are in atrial fibrillation. And there's consideration for more frequent fetal ultrasounds for those who are on a beta blocker. So this patient presented at 29 weeks with breathlessness and ankle swelling. Her BNP was great. It was 480. She had no pleural effusions or evidence of pulmonary edema, and she had an echocardiogram and her left ventricular function was good. So she's been commenced on diuretics and a beta blocker, and she's being reviewed in clinic monthly currently, and she's not yet delivered. But I'm going to hand over to Deepika to talk about what's to be considered in terms of delivery plans.
Thank you, Pam. I think the couple of things that we try to address when we are planning delivery is how should the patient deliver and what kind of monitoring do you need to suggest during delivery. I think it's fair to say that each case has to be individualized based on what the echo findings are, what the symptoms are, and what the past obstetric history is. Talking basically from the cardiac physiology point of view, it's fair to say that all the low-risk lesions, a spontaneous vaginal delivery or aiming for a vaginal delivery with induction is reasonable. And in high-risk lesions, such as the severe LV outflow tract obstruction or a severe heart failure, a cesarean section is suggested. But in the vast majority of the people, or the patients, not knowing how labor would progress, and the fact that an emergency cesarean section probably carries more risk than a planned elective cesarean section, there is a big element of choice, maybe anxiety, which makes them ask for a cesarean section. So whilst we don't suggest a cesarean section, there's a vast majority of people who actually elect to go for a cesarean section. In terms of monitoring during labor, I think the principles are to avoid any hypovolemia, and this could be seen in a setting of epidural analgesia with the fall in the blood pressure or postpartum hemorrhage, especially in prolonged labors, and then IV boluses of oxytocin. So the general principles are try and use a slow oxytocin or an oxytocin infusion cautious epidural and an early epidural, and monitor and treat postpartum hemorrhage aggressively. As Pam mentioned, the risk of arrhythmias are great, so some kind of monitoring of the heart rate is usually judicious in labor. And these are the kind of patients we try and keep them in the hospital for 1 to 2 days postpartum because, again, of the high risk of complications.
Great, thanks, Deepika. That's the end of the presentation. Does anyone have any questions?
Thank you both for that. There isn't at the moment, and I'm just conscious of time. Kate, did you want to go on to your next talk? And I'm aware you need to be away. Okay.
Yes, we'll do it just because there's likely to be a small change in the timetable because we're running over a little bit. So I was going to do 2 talks, one about dilated cardiomyopathy, and the second was a bit about women with pre-existing hypertension, but because a lot of the principles are very similar to managing women with sort of pregnancy-induced hypertension, we thought we would eliminate the hypertensive talk so that we can all get home at a reasonable time on a Friday. And I'll do my talk about dilated cardiomyopathy unless anyone has any huge objections.
Doesn't look that way, Kate, and there's no questions, so please crack on. Thank you.
And I forgot to put my camera on last time. Right, I think that works. Is that correct?
Yes, that's there. Thank you.
Lovely. So I'm also going to have a talk to you about patients who have dilated cardiomyopathy in pregnancy and those women who have pre-existing dilated cardiomyopathy as well. I'm hoping this is working. My screen sharing is being a bit strange. There we go. I think that's
it is there, yeah.
Lovely. So again, so I'm going to talk a bit, not necessarily about women who present with de novo heart failure during pregnancy, although obviously that's really important to have some understanding of. I'm going to talk a bit about assessing women who have known cardiomyopathy before pregnancy, or women who might be at risk of developing cardiomyopathy. And by cardiomyopathy for this presentation, we mean dilated cardiomyopathy during pregnancy. So this was another patient that we've looked after in Leeds, a 30-year-old who had a known family history of dilated cardiomyopathy in her father, and her father had what was probably an inherited cardiomyopathy with a variant of unknown significance in the RBM20 gene when we looked at his genetics. She had a known ejection fraction of 45%, and when she first presented to us, she was Parida 1 and Gravida 1. Sorry, she'd had 1 baby and she didn't actually present when she was pregnant initially. Her last pregnancy, she'd had an induction of labour at 37 weeks for maternal tachycardia, which in retrospect may well have been a presentation of cardiomyopathy. And she was normally maintained on bisoprolol 10 milligrams once daily and ramipril 10 milligrams once daily. And she was asymptomatic at the time that she presented to one of my colleagues for some preconceptual counselling. She actually wasn't using contraception at that point. She was a non-smoker and she had no other comorbidity. So I'll go on to talk about what we thought with regards to preconceptual counselling for her, but why is cardiomyopathy important during pregnancy? Well, we know that there are a number of women, and probably again an increasing number of women, who have pre-existing left ventricular dysfunction who are of childbearing age. And a lot of that will be inherited dilated cardiomyopathy, although there is also an increasing number of women who will have chemotherapy-associated cardiotoxicity or might have had myocarditis. Aside from the women who have LVSD, there are also a group of women who are at risk of developing LVSD prior to during pregnancy. So either someone who has a family history of a dilated cardiomyopathy, so we in Leeds will offer screening to women who've had family histories of cardiomyopathy throughout pregnancy, or maybe they've had prior cardiotoxic chemotherapy but have normal LV functions themselves. We know that dilated cardiomyopathy is problematic in pregnancy because many women will already be on medications which are problematic during pregnancy, in particular ACE inhibitors and mineralocorticoid antagonists. And we know that having adverse or abnormal left ventricular function before pregnancy is a risk factor for maternal poor outcome. So for women who are NYHA class 3 or class 4 or have ejection fractions of less than 40%, we know that that is associated with adverse outcome. And the really high risk groups of women are women who have ejection fractions of sort of less than 20%, atrial fibrillation, hypotension, or importantly have right ventricular failure. So when we're thinking about preconceptual counselling for these women, which we hope we would be able to deliver, those are the kind of factors that we might think about. So, as I said, we wonder what their left and their right ventricular function are. We think a little bit about what the etiology of their left ventricular dysfunction is and how that might relate to risk. So for somebody who has a scar in their heart from a previous myocardial infarction, but has good function everywhere else, that probably is a little bit less likely to deteriorate during pregnancy. But for a woman who has a dilated ventricle, maybe some functional mitral regurgitation, you would imagine that the hemodynamic stresses of pregnancy may increase their risk of deteriorating. Obviously, symptoms are important. Some assessment of biomarkers, ideally preconceptually, so that you have a baseline, and a functional assessment before pregnancy is really important because ejection fraction will tell us about, well, essentially the percentage of blood that's ejected from a heart. And whilst that is important, functional capacity and how that relates to a woman's ability to deliver a sort of a good peak O2 consumption is also important. And their comorbidities will play a role. For women who are hypertensive, who have LV dysfunction, that will present additional challenges in managing during pregnancy. Obviously, you want to have some idea about what their obstetric risk will be and what medications they are on. So with regards to this lady, as I said, her sort of diagnosis had been made a year or two before she presented to one of my colleagues for some preconceptual counselling. Her BNP was low. She had an ejection fraction that was reduced, but was stable at about 45%. And she had a normal VO2 max on a cardiopulmonary exercise test. We noted that she'd had a previous early delivery in pregnancy, but there weren't any adverse outcomes of pregnancy in her family. And by that, I mean, there were no women who'd had heart failure in her family during pregnancies. So my colleague suggested that she use some contraception. We thought that there probably was a degree of increased risk. We left her to go and have a chat with her partner, discuss her wishes, and we had planned to stop her ramipril and reassess her symptoms and her LV function. And that would be our usual practice, that if we're seeing women who have impaired left ventricular functions, but they're on medication, we'd usually like to stop that medication before they get pregnant, reassess what their heart muscle is, reassess their NT-proBNP and their functional capacity before they embark upon a pregnancy. It will come as no surprise to you that that's not what happened, that actually fairly shortly after leaving the fairly shortly after that appointment, she found out that she was 8 weeks pregnant. And she came back to one of our clinics. We stopped her ramipril at that point. We obviously discussed with her a sort of safety net. We talked to her about the risks. We continued her beta blocker that she was on. We did an NT-proBNP and she was doing well. And we saw her very regularly throughout her pregnancy. At 17 weeks, her ejection fraction was still 45%, again with a low BNP. But by the time she was 20 weeks pregnant, we'd started to see a slight decline in her left ventricular function. BNP was still normal at that stage, but she was starting to get a little bit more fatigued, a bit more breathless, and we elected to start her on some furosemide. And by that time, we'd started to think about delivery planning. She was fairly relaxed in that she was happy that we sort of offered her an induction of labour at around 37 weeks. This was some time ago when we were routinely offering inductions at about 37 weeks. We were starting to see her more regularly. She got a little bit more breathless. And at 35 weeks pregnant, she contacted our nursing team. She was getting more breathless. She actually didn't have any of her heart failure. her NT-proBNP had crept up slightly. And at that point, we actually admitted her to hospital. We added a bit of hydralazine. We continued her furosemide and her bisoprolol, and she had some bed rest and some fetal monitoring and went ahead with an induction of labour, actually at 37 weeks as planned. Her left ventricular function has never really recovered, though. So at 37 weeks, she had a delivery, and I'll talk about the way we manage that at the in a moment. But for women who have pre-existing left ventricular dysfunction, we just don't really know how pregnancy modifies their long-term outcome. And we think that there may be an adverse long-term risk, even for women who successfully manage their pregnancy without much complication, that time of increasing sort of cardiovascular stress whilst not being on medication has the potential to cause irreversible remodeling for these women that potentially will bring forward the need for additional medications, the need for defibrillators outside of pregnancy, or even the need for things like cardiac transplantations. And that is certainly something that is worth talking about when you're talking to women. For red flags in pregnancy for those women who have dilated cardiomyopathies, we will usually talk to them about breathlessness. We'll talk to them about orthopnea and PND. Obviously, persistent sinus tachycardia is something that would be an absolute red flag. When I did this presentation, PowerPoint just put an owl on for a nocturnal cough, which I quite like, so I've left it. But essentially, those are the red flags that might suggest that either someone who has a heart failure syndrome or impaired left ventricular dysfunction is developing worsening heart failure. But they're also the red flags that might suggest that someone who does not have heart failure is developing de novo heart failure during pregnancy. And I would recommend that for any of those women who have those symptoms, an urgent NT-proBNP and an echo would be a really useful thing to do. And just a reminder that NT-proBNPs, when they are normal, are less than 125. That's not the cutoff for NICE referral through to heart failure services. But I think it is worth remembering that women who've got BNPs of over 125, that's probably the time, certainly if they've got symptoms, that you should start to think about doing an echo for them. Of course, a BNP that's elevated doesn't necessarily mean they have heart failure, but as a screening test, it's well validated. For those women who have known left ventricular function during pregnancy, worsening symptoms is absolutely a red flag, as is increasing BNP. So understanding what their BNP at baseline is and tracking it through pregnancy is definitely important, and it's something that we do a lot of, as is declining left ventricular function. And it's usually putting all of these pieces of information together will help us make a decision about whether we need to expedite delivery or whether this is a woman that we're able to watch for a little while longer, add additional medical therapy, and maybe plan a delivery a bit later on in pregnancy. Just a word about managing heart failure in pregnancy, and heart failure is a clinical syndrome. So that means that it can be caused by a number of structural and functional abnormalities. So I think before you think about managing heart failure, an echo really is important, because there may be someone who's actually got a hypertrophic cardiomyopathy. It may be someone that's got decompensated mitral valve disease. But generally, thinking about diuretics would be important. If you have acute heart failure, intravenous diuretics. If you're presenting with a heart failure syndrome and your blood pressure is high, getting that blood pressure lower would be important. Beta blockers once someone is stabilised, maybe hydralazine. And obviously, if you are dreadfully unwell with heart failure in pregnancy, then delivery may be something that would have to be expedited. For those women who we've tracked through our obstetric cardiology clinic, with regards to thinking about delivery, it's really variable. For those women that we've just been screening throughout pregnancy to ensure that they continue to have a normal LV function and they've not got any symptoms, or maybe they've just got very slight reduction in systolic function but no symptoms and a low BNP, very often they can have local delivery. However, you do have to be aware that after and during delivery, there are changes that take place that might place increased cardiovascular stress on these women. So obviously placental autotransfusion post-delivery, the change in systemic vascular resistance that you get after delivery, It is, and this was complete news to me as a cardiologist, worth remembering about whether your patient's cardiac state might preclude a category 1 caesarean section. So for the cardiologists or the non-obstetric teams that are on this call, a category 1 section is a section that's needed to be done usually for something like fetal bradycardia, and there are specific times by which you will want to try and deliver that baby. But if a woman has a pre-existing cardiac condition, it might be that the anaesthetic team need more time to be able to safely give her a delivery. And so in some cases, it may be worth considering whether your patient is going to be able to have that, whether that cardiac state is going to preclude this, and whether that is one of those times when you might think about an epidural beforehand. Safety netting your patients is always important. Many women who have pre-existing left ventricular dysfunction, you will want to keep in hospital for a little while longer than you might otherwise do. And as we've all really said, avoiding that big increase in systemic vascular resistance post-delivery with avoidance of ergotamine and bolus syntocin is important. So for this lady, she had a planned induction of delivery at 37 weeks. She did have an early epidural and we delivered her in the tertiary centre. She was actually a Leeds patient anyway. We'd stopped. By this point, she was on a little bit of low molecular weight prophylaxis. You stop that in time to be able to give people epidurals at the right time. We kept her in hospital for 48 hours after the delivery, and then we obviously gave her some early follow-up. And the other thing to say is that for these patients, we might have, and I'm sure that all of the other teams in the talk will have a sort of a nice plan for a planned induction. But on the system somewhere, we always have a pull cord in case of delivery, in case of emergency plan in the medical notes. And I think that's really important to be able to provide teams at 3 o'clock in the morning with some reassurance that you've thought about what might happen if there's preterm labour, if someone suddenly develops worsening systemic hypertension in this kind of situation. And for all of these women, we will see them while they are inpatients. We will think about restarting medication appropriate to their level of left ventricular function, obviously with some regard to whether they're breastfeeding or not. And then thinking about risk factor optimizations, education, contraception before they leave hospital, and also thinking about what follow-up they're going to need from a heart failure perspective. So my colleagues or myself will usually see these women about 6 to 8 weeks following delivery. They'll get support from the heart failure nurses in the intervening period of time to try and optimise their medical therapy to a level that we're happy with. And that's me done.
Wonderful. Thanks, Kate. I think we did have one question slightly earlier on about would hydralazine worsen the blood pressure, the low blood pressure, and cause reflex tachycardia?
Well, yeah, so we wouldn't use it if someone was significantly hypotensive. But for women who have got heart failure and dilated cardiomyopathies, it's often something we introduce fairly early, particularly if, and many of these women have got comorbidities. Lots of them are a bit obese. Some of them are a bit older because they've been putting off getting pregnant. And I think the advantage of us sitting in a room with my obstetrics team is that we have sort of some appreciation about the other factors that might influence these women's pregnancies. So very often it's not their left ventricular function that becomes a problem. It's the fact that they get a bit hypertensive at the end of pregnancy, and that maybe causes a bit of decompensation. So we use hydralazine quite a lot, actually. Beta blockers, hydralazine, nitrates and diuretics.
Brilliant. Thank you. Right, we shall let you go, Kate. Thank you so much. I think we should still have a 10-minute break unless anyone has any objection to that. We'll still manage to finish off, I think, at 5 o'clock anyway, because we did have a big Q&A plan for the end of the day. So shall we reconvene at 20 to 4? Everyone happy with that? Great, thanks again. Welcome back, everyone. I hope you all managed to have a comfort break and grab a cup of tea or coffee. Pamela, are you happy to move on to your next presentation?
Yeah, absolutely.
Fabulous, thank you.
Okay, so my next presentation is I'm going to talk about aortopathy in pregnancy. So when we're considering diseases of the aorta, we can consider whether they're syndromic or non-syndromic. Syndromic diseases include Marfan, Lewis-Dietz, and vascular Ehlers-Danlos, and we also can consider whether it's heritable. The other thing to think about is whether there are any associated lesions such as bicuspid valves. Sometimes people with Marfan syndrome have mitral valve disease. And when we're talking about the aorta, in general, we're talking about the aortic root, an ascending aorta, but these are the kind of other parts of the aorta, the aortic arch and the descending aorta. And the abdominal aorta. As a cardiologist, I don't tend to get too involved in the abdominal aorta or really the descending aorta. Aortopathies can, can be quite low risk, sort of WHO category 2 people, such as people with Turner syndrome without aortic dilatation, all the way up to WHO class 4, which are the people with vascular Ehlers-Danlos or people with severe aortic dilatation, such as 45 millimeters in Marfan syndrome. So aortopathy is a huge topic. And so what I want to talk about actually to begin with is about acute aortic syndromes, and this is because here at South Tees in the last 5 years we've had somebody who was postpartum die from an acute aortic syndrome that was that there were some considerations that I will come on to, but to kind of cut a long story short, this is a young woman in her 20s who had a family history of aortic dissection. And she was being followed up. She had a successful pregnancy. I think it was her 3rd or 4th pregnancy, and she delivered. And she had echoes every month for 6 months following her pregnancy. But at 5 months postpartum, she presented with chest pain and a modestly raised troponin rise. She had a CT which was reported as normal and was subsequently discharged. She went back to her GP and came back to ED and was discharged and ultimately died of an aortic dissection. Aortic syndromes happen, and it's been flagged in the Embrace report that the risk of aortic dissection is increased 25-fold in pregnancy, and that chest pain should not be ignored in pregnant women or women in the postpartum period. And severe localizing pain or back pain, so either chest or back pain, is typical for aortic dissection. Often people are hypertensive when they present, and Embrace had this quite kind of like poignant line that any woman who leaves her baby to attend A&E at night requires a positive diagnosis, and that's what happened to the patient here. Most aortic dissections occur in the 3rd trimester or in the early postpartum period. And if you have an aortic dissection at a young age, then you should assume that's an inherited aortopathy. And there are consequences for that for the patient's family. And in aortopathy, a dissection can occur even if the aorta is non-dilated, so you shouldn't feel reassured by if they've had recent imaging of the aorta and it's demonstrated a non-dilated aorta. And family history, as I said, is really important. And the things that, we learned loads about this. So one is don't ignore chest pain in people who are pregnant or in the early postpartum period, and don't ignore recurrent attempts to seek help. Also, her troponin was mildly elevated. I think it was in the 20s or 30s. Our normal range is something like less than 22, and that was ignored, or there was no explanation given for why her troponin was randomly elevated. Also, family history. Her mother also died of an aortic dissection, and she had maternal relatives going back several generations who had had aortic dilatation or aortic dissections. We also learned the importance of a gated CT. So what that means is that the CT is timed along with heartbeat, and it gives better image quality. And although her CT was reported as normal, it was in fact, when it was reviewed by a vascular or cardiothoracic radiologist, it was actually felt to be not normal. So now we have changed our policy that anyone who is deemed at high risk for aortic dissection gets a gated CT, and their images get reviewed by cardiothoracic radiology the next day. And we also instituted an emergency healthcare plan. So if we think that people are at risk of having aortic dissection, then they have a flag on CAMIS, which is our admission system, that says this person is at risk of aortic dissection, and it links to the trust policy and how basically they should have imaging of their whole aorta if they present with chest pain or severe breathlessness or back pain. So that's just a case, and I think that I wanted to flag it because I think it goes to show that, in this person's case, she had appropriate monitoring. She'd got through her pregnancy. She was in the kind of postpartum period, and she'd had regular echoes, and her aorta was not dilated. So there was things that you could have been reassured about regarding this case, but actually she still presented with a dissection, and I think that that there was lots to learn, and I think it's worth sharing. So in general, people with an aortopathy, in terms of preconception counselling, then we need to consider whether they're on any medication. They might be on a beta blocker, for example, whether they've had any surgery, so they might have had a previous aortic dissection, or they might have had aortic root replacement. And the size of the patient is important, because a dilated aorta in somebody who's 6 foot and weighs 18 stone is maybe bigger than somebody who's 4 foot 11, like often people with Turner syndrome are. Their aortic size needs to be indexed to their body surface area. You need to know about family history, and they need to have imaging of their whole aorta, and this is an MRI scan, and you can see it demonstrates that this person's got an aortic coarctation, seen here at the beginning of the descending aorta. So don't be reassured by a normal echo. Echo is important to look for bicuspid aortic valve or other associated cardiac lesions. For example, as I said, in Marfan syndrome, you can get mitral valve prolapse. So, yeah, risk of dissection. 50% of dissections happen in the 3rd trimester, and a third happen in the postpartum period. So when we're considering specific aortopathies, Marfan syndrome has a risk of dissection about 3% during pregnancy, but it's been reported between 1 and 10% in studies. There are other associated lesions. If somebody's got Marfan syndrome, they should be advised not to get pregnant if the ascending aorta is greater than 45 millimeters or greater than 40 millimeters in a family history of dissection or sudden death. Bicuspid valves, usually it's the ascending aorta that's dilated. There's a low risk of dissection, but there is associated aortic valve lesions, and they should be advised not to become pregnant if their ascending aorta is greater than 50 millimeters. Loeys Dietz, there's a risk of dissection everywhere, and that includes in extracardiac arteries. So you might get vertebral artery dissection, for example, and there's a high risk of dissection in Loeys Dietz patients, and they should be advised not to get pregnant if their ascending aorta is greater than 45 millimetres or 40 millimetres in family history of dissection or sudden death. Turner syndrome. So Turner syndrome, people with mosaic Turner syndrome can get pregnant, and or sometimes they're pregnant due to IVF or assisted conception. And there is other associated lesions with the Turner syndrome, such as bicuspid aortic valve or aortic coarctation and hypertension. And their aortic size does need to be indexed to their body surface area. So anything that's greater than 25 millimetres per metre squared, they should be advised not to get pregnant. Finally, there's vascular Ehlers-Danlos, which is type 4, also known as type 4 Ehlers-Danlos. There's high risk of dissection, but also of uterine rupture and dural abnormalities, and all of these patients should be advised not to get pregnant. I would say that vascular Ehlers-Danlos is not the same as the kind of hypermobile type of Ehlers-Danlos, which is seen more frequently and doesn't carry the same risk. So in terms of antenatal care, you can monitor the aorta and up to 6 months, and they should be monitored. The European Society of Cardiology recommend monitoring for 6 months postpartum. And that can either, depending on the risk, can be either monthly or every 12 weeks. And that can be with echo. You can do a non-contrast cardiac MRI scan when people are pregnant. Usually it's best to do that in the 2nd trimester if you need to do it before the bump gets too big. People might need to go onto a beta blocker. To people with Marfan syndrome, for example, and the beta blocker of choice for somebody with vascular Ehlers-Danlos is celiprolol, which is a less commonly used beta blocker than, for example, bisoprolol. And strict blood pressure control is vital. Surgery is recommended for those who have progressive dilatation throughout pregnancy, progressive aortic dilatation, and that can be done if the fetus isn't viable, then it can be done with the fetus in utero, or it can be done with a caesarean section and then proceeding to aortic surgery. This needs to be an MDT approach, including obviously obstetricians, cardiothoracic surgeons and cardiologists. And if somebody has a type A dissection, then the fetal mortality is 20 to 30%. I will hand back to Deepika to talk about delivery. Is that okay, Deepika?
Yeah, thank you, Pam. So delivery should be planned in a cardiothoracic center. Obviously, if there is the unsaid complication, then you need some help. I think, again, the mode of delivery, there are certain criteria where you advise the cesarean section, like, for example, if the aortic diameter is more than 45 millimeters, because of the high risk of dissection, we do advise a cesarean section. And needless to say, the vascular Ehlers-Danlos syndrome pregnancy is contraindicated, but if you have such a patient who is pregnant, then probably we would suggest a cesarean section in that case as well. And as Pam has mentioned, if you have a dissection which you're going to treat surgically, then probably a cesarean section at the same surgical time would be valid. Generally, if the aorta is between 40 to 45 millimeters, it is safe to attempt a vaginal delivery. Again, every effort should be made to decrease the blood pressure spikes, such as an early epidural, to decrease the risk of pain-related high blood pressure. And again, try and shorten the 2nd stage so that there is minimum stress on the aorta. And we avoid ergometrin again because of the rise in the blood pressure.
Great, thank you. Any questions?
That's great. Thank you both very much. That was particularly interesting. Oh, Ken has his hand up. Ken, do you want to pop in there?
Just the point really is that quite a lot of the dissection happens postpartum, doesn't it? Certainly, we've had a recent woman with Loeys Dietz have a very significant dissection and needed transfer to Barts in London for surgery and hasn't done well at all. So I guess planning is, you know, the postpartum is actually really quite important, and sort of safety netting, giving the patient letters that says if you have pain, you need to have a CT scan, that kind of thing, really educating the patient and people around the patient that should she get sort of abdominal pain, you know, that needs to be taken seriously, I think is quite important.
That's right, Ken. I think in this particular case, that was a significant learning that we have derived. It was a very sad case. After a successful pregnancy, she happened to actually dissect months after the delivery.
Yeah, it must be, it's sort of devastating when that kind of thing happens, I guess. And yeah, I think just from what I've seen, it's just all anecdotal. I don't really have any evidence for it, but it does seem that the postpartum period really is a very high risk time. And almost we spend quite a lot of time in obstetrics planning delivery, and oftentimes don't really think too much about postpartum, but perhaps just, I guess the learning point for everyone really is just to sort of don't take your eye off the ball with these patients postpartum, and blood pressure control and giving them safety netting to come back if there's issues early is really important.
Yeah, completely. And we have a standard letter that we send to people.
Yeah.
Thomas, did you want to come in there?
I think that's really important. I think the postpartum period is probably the highest risk. And what you're saying about blood pressure management is a message that we really try and get across, because it's not actually often about blood pressure management. These people are normotensive, and it's about reinforcing that they are to stay on their beta blockers. And you know, the default within obstetrics is when someone becomes normotensive, the midwives will tend to stop giving, and the junior doctors will stop prescribing the antihypertensives. The labetalol, you know, just stops, and it's getting that message across that that shouldn't happen in these women. And you know, the same in some other cases, the long QT cases as well, who are on sort of protective beta blockers, carrying those on is not necessarily hypertension, it's for their own protection.
Thanks, Thomas. You said that just as Stephen Lord mentioned LQT there. There was one related question. Is that dissection months after delivery related to pregnancy? I think that's...
Yeah, I think it can take 6 months. Like, I think that you can have dissections up to 6 months associated with pregnancy. 6 months postpartum.
Great, thank you. And there was a general question: are women with cardiac conditions seen in community for any antenatal appointments, or would all their appointments be in a specialist clinic?
I mean, Deepika, you might be best to answer that.
Yes, maybe it's Deepika. Oh, you're on mute there, Deepika.
Sorry, it slightly depends on what your availability is. Like at South Days, we have once a month cardiac clinic, but I tend to follow them up in my MatMed clinic in between the cardiac clinics if there is necessity to follow them up more regularly.
Great, thank you. And just a related question.
Slightly different as a maternal medicine centre. For us, it's really important these women have their ongoing local antenatal care. They have their diabetes management, they have that ongoing, their blood tests, their anti-D, all the general stuff, all that birth planning, and link in with the community midwives for that postnatal care as well. So for us, the women who are coming into the maternal medicine centre, it's really important that all the normal things that would go on in normal antenatal care carry on and continue.
Wonderful. Thanks everyone for that. Right, I think we're on to arrhythmia now, and we have a trio: Emily Freer, Ken Hodgson and Stephen Lord. I don't know which of you is going to present this afternoon.
So Emily, I think, is going to present the first two cases. I'm going to present a case, and Stephen's going to provide us with the EP input.
Wonderful, thank you. Thanks, Emily.
Hi, can you hear me okay and see the slides?
I can, yes. You might just want to put it on presentation mode just so that it's a little larger.
Perfect. Okay.
That's perfect. Thank you.
Great. My name's Emily Freer. I am a subspecialty trainee in maternal fetal medicine at the RVI, currently working in Newcastle. So I have two cases of arrhythmias in pregnancy. These ladies are in fact both still pregnant, but I'm going to take you through the course of their pregnancies to date and how we've managed them, and would welcome input from Ken and Stephen at any point. I'm just going to change my slide, yeah, so I can see you both still. Great. Okay. So first lady is a 30-year-old. She is a nulliparous lady. This is a planned pregnancy. Only past medical history of note really is low-grade dyskaryosis on cervical punch biopsies, but no regular medications, non-smoker. And no family history of note, BMI 27, and normal blood pressure at booking. So she was seen in her local antenatal clinic at 12 weeks, so at booking, where she reported daily palpitations lasting from about 20 to 60 minutes at a time. She described that these had worsened since she'd fallen pregnant. She also described feeling breathless on climbing a flight of stairs, but wasn't breathless at all at rest. She was pre-syncopal sometimes in the mornings, but didn't have any actual episodes of syncope or no chest pain. So exploring the palpitations in a bit more detail, these had first started 18 months previously. They'd been quite infrequent at first. There were no obvious triggers. They occurred both at rest and on exertion. They had gradually become a bit more frequent over the subsequent year. So she'd sought advice from a private cardiologist who she'd seen about 2 to 3 months prior, at which stage she was actually found to be in the very early stages of pregnancy. So she, when she was seen by the private cardiologist, she had an echo done, which confirmed normal biventricular function, normal valves. She also had a Holter monitor, which showed very variable heart rates, episodes of atrial tachycardia with a maximum resting heart rate of up to 200, and short periods of AV block. So the plan made at her local unit was to refer her on to the regional joint obstetrics cardiology clinic, which in Newcastle is at the Freeman Hospital, and to refer her to the regional maternal medicine MDT. So at 17 weeks, she was seen at the joint obstetric cardiology clinic. She was seen by 2 consultant cardiologists, including Dr. Lord, who's a specialist in electrophysiology. She was seen by a consultant obstetrician in maternal medicine, and she was seen by a maternal medicine specialist midwife. Her observations are as shown. She had an ECG which showed atrial tachycardia, 2-to-1 heart block with a ventricular rate of 88. Her Holter monitor and echo that we've just discussed were reviewed. And some time was taken to explain the diagnosis to this lady, who obviously had only just really started having investigations for her symptoms. And the diagnosis was explained in the context of maternal and fetal risk. So she was reassured that essentially there were fairly minimal risks from this unless she was to develop significant sustained tachycardia with associated maternal hypotension manifested as syncope or frequent pre-syncope. She was advised that her symptoms may worsen as the pregnancy progressed, and was strongly encouraged to seek medical attention if she did start having any episodes of syncope or develop symptoms of worsening breathlessness or palpitations. So treatment options were discussed with this lady, again in the context of safety for mother and for fetus. These were outlined, so conservative, so watch and wait approach, commencing medications such as flecainide or bisoprolol, or a kind of less favourable option of ablation, which ideally would be avoided during pregnancy, particularly given its associated risks, including radiation and thromboembolic risk. She was reassured that she was unlikely to need a pacemaker. So maternal medicine management plan, which was put into her notes, which can be accessed both in the local unit and centrally, that the patient wished to opt for a conservative approach, but was agreeable to trying medications if she became symptomatic. She was encouraged that she could opt for a vaginal delivery, and that this could take place in her local unit. The patient did subsequently express that she wished to deliver at the RVI, but it would have been suitable at this stage for her to plan for a local delivery. A plan needed to be made for management of any intrapartum arrhythmias, and a plan to avoid ergometrin for third stage, given its pro-arrhythmogenic risk. So plan outlined in the notes was from following the clinic was for a 48-hour ECG to assess the extent of the arrhythmia burden. There was no immediate need for a pacemaker at this stage. She would have serial third trimester growth scans, an anaesthetic review, and a joint obstetric cardiology clinic in a month's time. This lady fell into the category B. Obviously, it's already been outlined in the talks, including by Caroline earlier, that this means she is a lady that can be managed with a kind of hybrid model of both local and central advice and guidance. So her subsequent antenatal reviews at 20 weeks, she was still having runs of tachycardia and was symptomatic of these, so started bisoprolol at a fairly low dose, and that plan was made to repeat her 24-hour tape. At 25 weeks, she was still having symptoms, mainly of a sense of a fast heartbeat, breathlessness, so her bisoprolol dose was increased. At 28 weeks, baby was growing well, normal Dopplers, and she was feeling good effect from the increased dose of bisoprolol. Her anaesthetic review, it was advised she could be treated as normal with regards to choices of analgesia in labour. We should consider continuous cardiac monitoring if she opted for an epidural. And if she did ultimately need a caesarean, then there should be consideration for an arterial line, but a standard spinal is considered suitable. So I might defer to Dr. Lord for these, but these are her 24-hour tapes before and after treatment. So this is before and after. I don't know if there's any particular comment you'd like to make. Oh, I think you might be muted.
Sorry, I'll butt in there if that's okay. And there also should be some ECGs, but we'll maybe come to them. But I think this is the crux of it, really. You'll see from the ECGs in a minute that this is a form of SVT. It's a slightly unusual form of it, which spooked everyone. And you'll see that Emily from time to time has emphasised the fact she didn't need a pacemaker, not because anybody, you know, by the time she came to the clinic ever thought that she would, but the kind of latched on, or somebody had told her that she had heart block, which she sort of had, and I'll show you that from the ECG in a minute, but that was really nothing to do with it. So I would put her very firmly in a low risk group, because essentially she has a form of SVT. And you know, outside of pregnancy, there are three options. The first is to do nothing. Second is to try some kind of tablet, mainly with the aim of controlling the rhythm or possibly stopping it. And the third would be an ablation. And for a young woman with this sort of arrhythmia, I would often offer an ablation in this situation, although at some risk, as we could discuss if you wish. I mean, ablation is a theoretical option during pregnancy, but very much as the discussion earlier around the mitral valvotomy, it is not something that you would attempt unless you really, really had to. And I would think you would have to think very, very hard before doing that for SVT. Anyway, so coming back to this slide here, you can see the top left is the 24-hour tape before treatment, and the bottom right is that afterwards. And again, you'll have to see this in the context of the ECGs. It essentially has an atrial tachycardia, but you can see that you can just about see the numbers on the left-hand side here. The scales are about the same, so my arrow is around about 100 beats a minute there and there. And we opted to give her a beta blocker, and you can see that what the effect of the beta blocker has been to stop there being sustained periods of very rapid heart rate. And we recognise that sustained, rapid, uncontrolled atrial arrhythmia, often with 2-to-1 or even occasionally 1-to-1 conduction can lead to ventricular dysfunction, or certainly can lead to unhappiness, significant symptoms. And beta blockers are a good way of controlling that. If you said to me which medical treatment is most likely to control this rhythm, then I think you would be better, if you really wanted to try flecainide. And just as an aside, if you try flecainide on its own with an atrial arrhythmia before you give a beta blocker, then you may simply slow the atrial arrhythmia and change it from 2-to-1 to 1-to-1 conduction. Emily, I don't know whether you want to move to the next slide. If we've got ECGs, have we?
I have one ECG. I'll just try and share it now. This
they
is
are.
the ECG here. This is the one. Try and make it bigger. Yeah, that was the only ECG I've had for this lady.
All right, so this is yeah. So this is interesting because the other thing is that it looks remarkably normal, and the point of showing this ECG is that if you look, even with a quite educated eye, you could what you can see is here. Firstly, is that there is a regular ventricular response which isn't going that fast. And it appears there's a P wave before every QRS. And I guess the curiosity about this ECG is that, in fact, if you look really, really carefully, and I'm not sure whether I can zoom in or anyone can, but and you maybe have to believe me that this is in fact an atrial tachycardia with 2-to-1 block. Now, I'm not expecting anybody either to get that or to understand it, but and I think the point I want to make really is around the fact that this lady had. I mean, you've told the story quite succinctly, Emily, but I think this lady had been around a bit, and her husband is a GP, I think, as well. And she'd been around a bit with her symptoms for quite a while, and at the end had gone to a private cardiologist and got an ECG. And people will miss things or just say, oh, it's sinus tachycardia. And if you don't do an ECG, you won't find it. And if you don't look carefully and report it properly, then you won't find it. And so I guess that's the point I want to make from that. So anyway, in summary, we have ended up just treating her with a beta blocker. You'll see she's on pretty low dose. And that actually has been enough in this situation. And this is the ECG. The ECG you're showing, Emily, is the ECG after treatment. There's one before which is going faster. And the outcome of treatment has simply been to control the rate. It hasn't been to get rid of the arrhythmia. If you wanted to get rid of the arrhythmia pharmacologically, you could then add flecainide to the beta blocker, which would prevent the possibility of paradoxical increase in the rate due to 1-to-1 conduction. And the thing about beta blockers is that everybody's happy with them, and they're happy with them during pregnancy, and we all know what to do, and we can all monitor them. And as again has been said earlier, whilst there may be a small reduction in the amount of growth that the baby will get, that's entirely understandable, manageable, and is generally considered to be low risk. Other drugs such as flecainide, after the first trimester or maybe even before, are probably safe, and I'll leave Ken to comment on that. But had this woman had ongoing difficulties for whatever reason, then that would be the drug I would try next. Anyway, I'll stop there.
Okay, thanks. Right, I'll just come back and share it. Bear with me. Case 2. Was this the other one?
That is the ECG. Anyway, you can move on because I kind of talked about that.
Okay, thank you. Okay, so next case is also a 30-year-old nulliparous lady, also a planned pregnancy. So this lady has she's been diagnosed with dilated cardiomyopathy, which is felt to be secondary to RVOT ectopy. This presented when she had a collapse at work, working as a nurse. She had loss of consciousness. She was admitted to the Freeman, and monitoring at that time showed ventricular bigeminy with occasional non-sustained VT. She had a cardiac MRI, which showed a dilated and globally impaired left and right ventricle with an LVEF of 43%. There was no evidence of any edema to suggest this had been caused by inflammation, and no evidence of scar or focal fibrosis. So it was unclear from the MRI of any kind of other underlying cause to identify the etiology. There was also no family history of cardiomyopathy. So the lady was started in bisoprolol and losartan. This is all at the time of diagnosis, several years prior. But the subsequent year, she had ongoing symptoms and ventricular bigeminy ongoing, and LVEF of 30%. So she had ablation procedures. She had 2 done, and subsequently had significant improvement in her symptoms. This is the 24-hour tape from post-ablation. So I don't know if you might like to jump in at that point, or if you'd prefer to talk at the end, either or.
No, well, I probably should explain the slide.
Okay.
Essentially, I wasn't involved with her at this stage, but she had presented exactly as Emily has said, a bit younger, 6 years before now. And and sadly, because of the way the electronic record happens in our hospital, or happened or evolved, we don't have the very original presenting tape and the frequency of the of the ectopy. She had what was felt to be at least possibly an ectopic induced cardiomyopathy. Therefore, she had 2 ablations, which I think it's probably fair to say were partially successful. This is just 2 graphs, one on top of the other. The one on top is the tachygram, that's the heart rate over 24 hours, and on the bottom there's the frequency of the ectopy. And the number that we're interested in, I suppose, is the overall frequency. And as a ballpark thing, and it's much debated, then what we would say is that people who have a frequency of ectopy of less than 10% are very unlikely to have a cardiomyopathy due to the ectopy. Those between 10 and 20% may do so, and those above 20% are likely to do so. Now, it is not as simple as that. And just to summarize what happened to this lady, she was quite bad. She probably had more ectopics than this, but we can't find the evidence. She had an ablation. Some of them went away and she got better. And as Emily will show you, her heart function, as well as her symptoms, her heart function improved as well. Now, it is notoriously difficult to prove this because heart function can improve for lots of other reasons, not least the medication and the passage of time. And it's often the case that is more than one process going on. So you may have a cardiomyopathy, which is both due to an inflammatory component or a genetic component or some other cause of the cardiomyopathy, remembering that the word cardiomyopathy just means something wrong with your heart muscle, and those processes can cause the ectopy in the same way that the ectopy can cause the cardiomyopathy. So which one is which? Well, it can be quite hard to find out. In this case, it does seem at least possible that the ectopy was to some extent responsible because of the improvement after ablation, but it's not as clean as I would like it to be. Anyway, back to you, Emily.
Okay, thank you. So at the time of booking, we'll jump back in time in a minute, but at the time of booking, she was on bisoprolol 10 milligrams. She had previously been on losartan and spironolactone. Other past medical history relevant is that she also had idiopathic chronic hydrocephalus with a ventricular peritoneal shunt inserted in 2017. She was fairly well from that perspective, having previously had issues with headaches and visual disturbance. She also had subfertility and had conceived on Clomid. She was a non-smoker with a normal BMI, and as you can see, quite a low booking blood pressure. So in 2021, this lady was asymptomatic and expressed a wish to start a family, so was referred appropriately for preconception counselling. Cardiac MRI around that time showed an LVEF of 52%, although it was noted that there was quite significant ectopy during the scan. 24-hour tape showed an 11% residual ectopic burden. In anticipation of hoping to conceive or be given a green light, she stopped losartan and continued on bisoprolol 10 BD. She was seen in the regional preconception joint obstetric cardio clinic. It was revisited the fact that the etiology of her diagnosis was unclear, as Dr. Lord had alluded to, but it was felt probably most likely to be RVOT ectopy causing LV dysfunction. Her echo in the clinic showed moderate left and right ventricular dysfunction with an LVEF of 40% and a dilated left ventricle. And as such, the lady was advised at this stage against falling pregnant. She was advised to restart her losartan and add in spironolactone. The plan had been to review her response to treatment within just over a month's time. She was advised that they may be able to support a pregnancy at a later date, depending on her symptoms and, well, depending on her function. It was also suggested at this stage that she could have some input from the genetics team to inquire into testing for a possibility of an inherited cause. And obviously the patient was understandably really upset and disappointed and requested a second opinion just to revisit things. So this was the ECG at the time she was seen in that clinic. If you wish to. Oh, you're muted at the moment.
That shows just frequent ventricular ectopy.
Yeah.
It's monomorphic, I suppose, is the thing you can see. You can't quite see them under there. It's not absolutely typical RVOT. So it raises the possibility. It makes another sort of cardiomyopathy a little bit more likely, but it's consistent with the known diagnosis. Let's put it that way. There's nothing more exciting going on.
So she was seen about 3 months later by another cardiologist in the same clinic setting. At this stage, having notably restarted losartan and also started spironolactone, she was asymptomatic and NYHA class 1. An echo in clinic at this point showed a low normal left ventricular systolic function of 50 to 55%. Her NT-proBNP was confirmed to be normal. And by slightly later on that year, she had undergone genetic testing for potential inherited cause of cardiomyopathy, which had returned back with no evidence of any mutations found. At this stage, cardiopulmonary exercise test was arranged. This was reassuring. There were no arrhythmias reported. And in light of all of this, her pregnancy wish was at this stage supported by the cardiology team, obviously with caveats. She was advised to stop her losartan, stop spironolactone, and continue on bisoprolol. And the plan was to review her, as very similar to the case described by Kate in the previous talk, to review her off treatment quite soon afterwards, to repeat her echo and repeat the cardiac MRI. So at that stage, off the losartan and spironolactone, her echo was fairly stable, and notably her LV function when in sinus rhythm was normal. So she fell pregnant and at 13 weeks was seen in this clinic, the Joint Obstetric Cardiology Clinic. Again, this lady actually had booked her pregnancy elsewhere, I think in Carlisle, but was seen at this stage in the Freeman. She was asymptomatic at 13 weeks, NYHA class 1, modified WH score 1 on bisoprolol 10, just once a day. Her ECG was a normal sinus rhythm in the clinic, and echo showed an ejection fraction of 55% with a mildly dilated left ventricle. 70 weeks, she was a bit hypotensive, but symptomatic of being slightly hypotensive. So her bisoprolol dose was split morning and night. Her palpitations at this stage were absolutely fine. Her echo was stable, and a subsequent plan was made. So her antenatal care and delivery could be managed locally. Again, this patient actually opted for delivery at the RVI, but the plan was that she could have delivered locally. And the plan, as per a Category B patient, was that we could liaise with the, her own local unit via the regional maternal medicine NDTs. The plan, as I'd mentioned, was to continue on bisoprolol with a split morning and night dose given her symptoms of low blood pressure. Serial growth scans given she's on bisoprolol, anaesthetic review, and repeat review in the same joint obs cardio clinic with another echo at 28 weeks. With regards to mode and timing of birth, again, this lady was encouraged that she could have a vaginal birth, and we would generally recommend this around about 37 to 38 weeks with no clear indication for a caesarean based on her cardiac history alone. So subsequent antenatal course, 27 weeks, she was completely asymptomatic. 30 weeks, unfortunately, she'd had a patellar fracture and was in a leg brace, so was started on some low molecular weight heparin prophylaxis. ECG sinus rhythm, echo stable, slightly more dilated, left ventricle ectopy noted at the time of the echo. She elected to have a caesarean section, purely maternal request, I think in the context of her subfertility and other aspects. She expressed that she had previously been told that she would need to have a caesarean, and had several reasons for electing for that. So that plan was put in place. At 31 weeks, she saw the anaesthetist, who discussed they would plan for an arterial line, a single shot spinal, an echo soon before delivery, and caution with syntocinon, as has been alluded to in other talks today. And we saw her just very recently in the joint obstetric cardio clinic, at which time she was very well, has a caesarean booked for 37 weeks with a plan for postnatal echo at 48 hours after birth and postnatal cardiac follow-up in place. So some key learning points from these cases, which we may have time to elaborate on, is obviously, particularly with the second case, these conditions can really fluctuate in their severity, and thereby actually over quite a short space of time, the conception advice can also vary. Effects of pregnancy on arrhythmias, obviously the symptoms often worsen in pregnancy, and in the second lady, she was quite symptomatic on the bisoprolol laterally, as she reached that drop in the physiological drop in blood pressure around about 17 to 20 weeks, but that can be managed quite effectively by making some customized modification to medications or regimens. Specialist MDT input is key, especially if things are slightly more complex, as per the second case, and obviously it's been invaluable to have input from a specialist in electrophysiology, and finally, care can be facilitated at local units for some slightly more complex cases, with ongoing review and advice from regional maternal medicine centres. So that's all I have.
So
Thank you, Emily.
yeah,
Thank you very
that's
much.
really good. So I would just add that I mean I would completely agree with all that. Obviously, I think the other thing that comes out for me, particularly just listening to the way you present it, which is really good, is but it's something that's important to understand, because I'm not an imager myself, but the challenge of imaging these patients where they have a lot of arrhythmia is that, for instance, both